Good morning. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Thursday, April 11th, 2024. The time is 9:30 a.m. Today we are live and in person in Council Room 123. We are also broadcasting live via the Zoom internet platform on Channel 13, as well as my YouTube page at CMC Henderson. I'm reconvening this meeting of the Committee on Health for the second of two hearings for the FY 2025 Department of Behavioral Health proposed budget. Yesterday, we held a hearing, heard from public witnesses, and today we will hear from Dr. Barbara Bazaran, who is the Director of the Department of Behavioral Health. The Department of Behavioral Health, often referred to as DBH, provides prevention, intervention, and treatment services and supports for children, youth, and adults with mental and/or substance abuse disorders, including emergency psychiatric care and community-based outpatient and residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government programs. DBH also manages the district school-based behavioral health program and operates St. Elizabeth's Hospital, which is the district's inpatient psychiatric facility. Yesterday, we heard from more than 50 public witnesses, including students, parents, community-based providers, interested community members, and advocates. They discussed the need for increased resources for school clinicians and behavioral health staff, substance use prevention, treatment, and recovery, early intervention, and crisis recovery services. I don't see any of my colleagues here. Just for awareness, every hearing room is full today. We have lots of government witnesses who are testifying today for a lot of big agencies. So folks will be cycling in and out. So in advance, appreciate you all's accommodations there. But I'm going to go ahead and go to Dr. Bazaran for you to give your opening statement. But before you begin, I need to swear you and your team in. So I'll ask for you or anyone who may speak today to raise your right hand. Okay. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia and this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. When you're ready.
Good morning, Chairperson Henderson, council members, and council staff. I'm Dr. Barbara J. Bazaran, Director of the Department of Behavioral Health. With me today is Adrian Reed, Agency Fiscal Officer, Michael Neff, Chief Operating Officer, and Mark Chastain, Chief Executive Officer at St. Elizabeth's Hospital. I am pleased to testify before you today on Mayor Muriel Bowser's proposed fiscal year 2025 budget that invests not only in a safer, stronger DC right now, but also looks ahead and includes investments that will accelerate our comeback and increase our capacity to make big investments in the out years of our financial plan. The mayor's budget continues strategic investments in behavioral health care that allow DBH to maintain and expand its core functions to meet the needs of residents with serious and persistent mental illness and substance use disorders who rely on the public behavioral health system for quality care. Residents receive treatment and recovery supports primarily through the DBH certified network of community-based providers. DBH provides crisis services, operates adult and child urgent care clinics, manages St. Elizabeth's Hospital, which provides 24/7 inpatient psychiatric care. As the state behavioral health authority, we are also responsible for addressing the mental wellness of all district residents. Under the leadership of Mayor Bowser, with the guidance of Deputy Mayor Wayne Turnage, DBH supports healthier and stronger communities by working to prevent the onset of mental and substance use disorders by providing a range of community-based treatment services and recovery supports. Mental health is health. A person's mental health can change over time depending upon many factors and changing circumstances. Gun violence and safety concerns place additional stresses for too many of our members of our community. In FY24, nearly 43,500 people received behavioral health treatment through the Department of Behavioral Health. Mayor Bowser's proposed budget for DBH addresses the increased need and ensures that residents can get connected to the care they need by phone, at home, in school, or in the community. The proposed FY25 budget continues support started during the pandemic to meet the needs of residents with moderate or mild depression and anxiety. The proposed FY25 budget supports the transformation work underway with our partners to provide residents with an integrated, high-quality, more equitable, culturally sensitive public health system to address the mental health needs of all of our residents. This transformation supports better care coordination and case management, essential to whole person care to achieve optimal health. It also strengthens the provider network to support enhanced quality of care. The intended outcome of our transformation efforts is healthier people living longer, more fulfilling lives. I will now present an overview of the proposed FY25 budget for DBH. We provided responses to the committee's pre-hearing questions and appreciate the collaboration of the committee staff. DBH's FY25 budget formulation is driven by our absolute commitment to focus on our core mission, fund approved state rate adjustments made in FY20 and 24, and maintain essential services. The mayor's proposed budget for DBH reflects these priority areas. The proposed FY25 gross operating budget is $385,536,240, which is a slight increase over the FY24 approved budget. The proposed FY25 capital budget is $7,280,000 for facility projects at St. Elizabeth's Hospital. Before I get into the details of our budget, I want to take a moment to put our department and our budget in context. Just as we are requiring providers to achieve national accreditation to enhance quality of care, we also are seeking accreditation for government-operated services, our early childhood program, crisis services, and adult urgent care. In our closeout meeting with the Commission on Accreditation of Rehabilitation Facilities, or CARF, the team was amazed at the range of services provided, including our unique 24/7 crisis response team. They were also impressed with the knowledge and dedication of our employees and the number of psychiatrists we had. They said they would love to hire some of them. I couldn't have been more proud. These achievements are due to the historic investments by Mayor Bowser and the council, as well as past mayors and council. I especially want to acknowledge Councilmember Gray, who established the Department of Behavioral Health in 2013 to integrate treatment for mental health and substance use disorders for better health outcomes. I will share a few budget highlights and provide more details in our discussion. This includes $53.9 million for mental health services, which will support $180 million in services when matched with federal dollars. $23 million in local behavioral health services for residents without insurance. $28.9 million to maintain supported housing for 1,700 residents. $52.6 million for substance use disorders. $21.7 million for crisis services for children and adults. I want to note that since the launch of the 3-digit 988 number for the Suicide and Crisis Lifeline in July 2022, calls have increased by 76%. $50.4 million to support children, youth, and families. That includes $7.3 million for prevention and early intervention services, and $112 million to support St. Elizabeth's Hospital. I'd now like to discuss Mayor Bowser's enhancements to the proposed budget. $17.3 million for local matching funds for Medicaid eligible behavioral health services, for a total of nearly $53.9 million. This amount will support nearly $180 million in total services when matched with federal dollars. The proposed increase supports new services, including clinical care coordination and evaluation and management services, and increased utilization. The additional funds also continue rate increases begun in the last 2 fiscal years for 22 services, including 9 evidence-based practices for children and youth. $4.9 million in local funds to stabilize funding for the community response team, crisis services, and intensive care coordination with the end of ARPA funding. $4.3 million for contractual obligations related to collective bargaining agreements and overtime costs within St. Elizabeth's Hospital, and $2.5 million for CPEP to support 10 FTEs. $1.8 million for additional services at 25 schools with the highest needs through grants to CBOs, and $600,000 to continue 3 targeted behavioral health outreach pilots in wards 1, 5, and 7, established by council with one-time funding in FY24. I will now detail the decreases in the proposed budget that result in major savings that allow us to make the best use of our funds and resources. $11.6 million to realign community support to reflect utilization trends. Upon enrollment, everyone will receive automatically 200 units or 50 hours of community support for a 180-day period. Another 200 units will be automatically granted with an updated treatment plan. Currently, 90% of consumers use less than 400 units a year. I want to emphasize that no one will be denied the care that they need through community support. Additional units will be granted based upon clinical guidelines. $5.9 million reduction in fixed costs in telecommunication, and $4.8 million in the school-based program savings. The savings are funds that have gone unused for schools that had never been matched with the community-based organization and schools that have been unable to recruit a clinician. Let me be clear. $28 million remains in the school-based program to support services and supports for all 254 schools as we reimagine the service delivery model. This decrease does not affect any existing school partnership or impact the funding of any existing school-based clinician. I look forward to discussing this in more detail. $2.1 million due to the elimination of 31.1 vacant FTEs. And lastly, $922,833 with the discontinuation of the urgent care clinic located at DC Superior Court due to low utilization. The proposed FY25 budget continues support for children and families at home, in school, and as needed during crisis. Children and young people have been particularly impacted by the pandemic as disruptions in routine and relationships have led to increased social isolation, anxiety, and learning loss. Studies show that the use of social media also has created anxiety and depression for some young people as it presents a warped view of reality and presents challenges with body image and self-esteem. The proposed funding of $28 million for the school-based program will support all 254 schools with more effective use of our clinicians and better interface with the school-hired behavioral health team in each school that could include the school social worker, a lead teacher, a school nurse, and a parent that is led by the school-based behavioral health coordinator. To guarantee the delivery of prevention and intervention services that are not eligible for Medicaid reimbursement, DBH provides $80,819 per clinician for salaries. The funds also support workforce development and supervisory support. This number will not change in the proposed FY25 budget. I am excited about reimagining the model and evaluating 2 pilots now underway that give more flexibility and ensure that we are using our significant resources in the most effective way to reach students and families who need support. I now want to provide a brief update on Live Long DC. The FY25 budget includes authority for $36 million in the state opioid response program, Live Long DC, which supports evidence-based prevention, harm reduction, treatment, and recovery strategies to fight the opioid epidemic. The budget also includes authority for $14 million for the opioid settlement fund in anticipation of additional revenues. While the dollar amount may change, the authority will allow us to spend once the budget is approved. Driven by the deadly synthetic fentanyl, opioid overdose deaths continue to climb. The chief medical examiner reports that 518 overdose deaths occurred in 2023. The majority were DC residents and most in their homes or the homes of family and friends. We are steadfast in our resolve to reduce opioid use and related deaths. During 2023, fire and emergency medical services and community partners reported about 8,500 suspected overdose reversals using naloxone. That's hundreds and hundreds of lives saved, often the lives of people who had no idea their drug contained fentanyl. DC is leading the nation in the distribution of free naloxone, free to anybody. We're doubling down on making naloxone easy to get at home, in school, pharmacies, community sites, and faith homes because we know it saves lives. When our community partners distribute the harm reduction tools, they also engage with users to build relationships and trust that might get them to start or restart treatment. I want to end my testimony, as always, by recognizing the essential leadership of peers and their integration throughout the system of care supported by the proposed budget. 3 in-person peer certification trainings are scheduled each year. Peer specialists now work in the provider network with treatment teams and community hospitals, emergency departments, our emergency care facilities, and at St. Elizabeth's Hospital. Consumers conduct the annual Consumer Satisfaction Survey. In addition, DBH funds 4 peer-operated centers. In conclusion, Mayor Bowser's proposed FY25 budget for DBH provides ongoing and new investment that support the opportunity for residents with behavioral health needs to live longer, healthier lives. Madam Chair, we appreciate our partnership and the work of the committee and look forward to our continued work together. I am ready with my team to address any questions you may have. Thank you very much.
Thank you. Thank you to you and your team for being here, and for the responses that you all provided in terms of the pre-hearing questions. I'm just gonna go, I'm not gonna put myself on a clock until a colleague appears. I think I'm expecting someone in about 15 minutes or so. So when they get here, I'll stop and let them get started. Okay. Let's start with school-based behavioral health program. We heard a lot of testimony about that yesterday. I've also sort of been around the council enough to know that words matter in testimony. So you specifically say we are, quote, reimagining the service delivery model. And what does that mean exactly?
Well, essentially, we are re-looking at the framework that we are currently using and the design that we are currently using. And as you know, we have created some pilot programs. One pilot, for example, based upon the feedback we got from the provider community, was to give the funds directly to our charter schools, because they said, we know our community better and we're able to really capture and hire quicker. And so we've done that. And I think that that's one of the things that we've done. And as a result, we have had 7 schools accept. In addition, we looked at a hybrid a telehealth model, where the clinician could be on site for 3 days and through telehealth for 2 days. And this basically is really focused on the high school and older population. And we have had 3 of our CBOs who have entered in agreements for those. These are just 2 of our pilots. We hope to expand that so that we can, in fact, increase the number of clinicians that are available. The other thing we have learned, and that is directly from the cohort 4 schools, is that many of these schools feel that they only want prevention and intervention services. They don't want treatment services. They said, we already have that within our school. And so in that instance, you could use 1 clinician to serve 2 schools, therefore covering more schools, providing the services and supports that are needed based upon the needs of that school. And so these are some of the things that we're thinking about. And as you heard during testimony, the providers are really interested also in continuing these discussions that we have begun to have with them around how do we best use the resources we have to ensure that everything is covered.
Okay. So that was a lot.
Well, I'm just saying.
No. That was a lot. So let's break it down just a little bit. So Because we're making some changes. There is still a $10 million decrease. Now, I know a lot of that came from ARPA funding, a lot of that coming from vacancy savings, et cetera. Within the health committee, we are very familiar with, I'm not even gonna call it a cluster model. We're gonna call it shared services amongst multiple schools, for which we've gotten some very mixed feedback. We have that going on right now in the school nurse program. But at the end of the day, the clinician is still only going to get paid, or the CBO is only still receiving approximately $80,000.
$80,819.
Okay. So the breakdown that I have for what that goes to,
Mhm.
63,000 for the clinician's salary for
Correct.
non-billable services,
Mhm.
16,666 and some change for supervision.
Mhm.
Doesn't that actually go to the CBO?
It goes to the CBO for, actually for supervision, because what we know is we have more LGs who are
Yep.
not licensed. And to move towards licensure, they have to get those hours. It's very costly.
Oh, yes. No, no,
And
no.
so this allows them to get free supervision while they're doing their work.
Okay. And then you have $1,000 for workforce development.
Correct.
All right. So at the end of the day, if I'm a clinician in this role, the maximum I'm taking home is 63.
That's correct.
We heard testimony yesterday from the DC Behavioral Health Association that that's what, about 20% less than someone can make in their profession outside of the school-based mental health program.
Well, quite frankly, the CBOs establish the salaries for their clinicians within their particular organization. And,
But you know the financial history of some of these
I do.
CBOs. They
I
can't
certainly do.
afford an additional
I certainly-
20,000.
Yes, I certainly do. And also, Madam Chair, I would like to say that there is also, remember, additional dollars that could come from billing. And I actually met with all of the leaders of the CBOs
Mhm.
to find out, so how are we doing in terms of billable services? What are your expectations for your clinicians? The expectations that I have heard is the ranges between 10 and 15 clients in terms of getting billable services done. And that adds to the amount of money. Remember, this model is based upon the fact that the Department of Behavioral Health would pay for 50%, and then 50% of the services would be billable.
Okay.
Now, we recognize that private insurance still is an issue.
Hmm.
And particularly what we were told are the copays are the big issue for a lot of families. And so that's something that, we need to look at.
Okay. So, I mean, I think that, okay, I guess in the model, particularly when we're talking about social workers, they include supervision hours as part of your compensation package. But in terms of the base salary, we're talking 63, not 80.
Mhm.
Um, Now, if I'm making 63-ish, and now you're going to tell me I have to do multiple schools, what's our plan there in terms of when are you all going to start to communicate with some of the participating schools that they're not going to have someone who is full-time, that they're going to share? Are there going to be, are you doing it by geography? Are you doing it by size of school? Like, what's the communication plan?
Well, I think the communication plan is as follows. First of all, these changes will not take place until FY25. And so we do have a little bit of leeway. But however,
Okay.
what we know is that based on school need, we can cover at 2 schools with a clinician. We have done this before. This is not new. The school-based program, when it first started under the Department of Behavioral Health, many of our clinicians covered 2 schools, and we did not find that to be problematic.
Right, but
Yeah.
we eventually moved to the model of desiring to have one person in every school. And the reason I'm pushing you on this is only because we literally just went through this with DC Health, where we went from a model of having or desiring one nurse in every school, one nurse or registered nurse or LPN in every school. And now we have a cluster model. And it hasn't exactly gone as well as everybody has hoped in terms of implementation. So that's why I'm pushing you on what is our implementation plan. And I know you say, oh, it's FY25, but really it's the start of school year 24, 25,
course.
which begins in
Right,
August.
right.
So I want to allow for schools to have time to maybe readjust if they desire that they want to have someone in the building full time. Maybe, they want to hire an additional person to cover the other, 4 hours, 6 hours,
Right.
whatever. So
And-
that's why I'm saying, like, how are we going to
And
communicate
but I
this?
think the other thing too, council member, that we have to think about, and that is that the school-based clinician is not the only clinician in the school.
Right.
If you look at what happens in schools, there are social workers, there are full teams that are there, and our clinician is a part of that team and works with the other clinicians in the school to provide the level of care that's needed and the services that are needed for those young people.
Okay.
And so that's also a factor for consideration.
All right. So you say in your testimony, quote, this decrease does not affect any existing school partnerships
That's
or
right.
impact the funding for any existing school-based clinicians. So what I'm hearing from that in terms of the use of existing is that if you currently have a person,
So you will have a person.
you will have a person.
Right.
Anyone who currently is not matched or does not have a clinician, there will
Mhm.
be an adjustment made.
There could be an adjustment made based upon the needs of that school.
Okay.
So for example, as I said before, a lot of the cohort 4 schools are saying, we really don't need a full-time clinic. We don't need treatment services.
Got it.
We
They
just
want
want
prevention
care.
and intervention.
That's it.
Okay. All right. So let's talk about the pilot for a second. So first off, I want to express appreciation to the department for hearing the charter schools, for hearing me when we sort of raised this of like, hey, this is a new thing that they want to try and see if they can do. We got to start it a little late in terms of that. Is the idea that the pilot for the existing 7 schools will be able to continue
Oh,
for
absolutely.
FY25?
Yes, absolutely.
Okay.
Yes. And if others want to join, we welcome them to joining the pilot. So if there are other places where we can expand the pilots,
Mhm.
we would like to do that.
Have you had any conversation? I actually don't even know if it would work with a DCPS school. I know for charter schools, it's easier because they're their own LEA. They have a bit of a more fungible budget in order to be able to sort of make some of this work. But I'm curious if you've heard from any DCPS schools who have expressed an interest.
Well, particularly, yes, around the hybrid, the telehealth model.
Okay.
Yes, and particularly for high school young people.
Okay. So will the hybrid telehealth model also be a pilot or
It is a pilot now,
currently?
currently.
Okay.
Mhm.
So this might explain a little bit of some of the students who come to testify and say, I don't see the clinician in my school. It could be because they are on a hybrid or
Well, there are only 3 of those going on at this time.
only 3 schools
Only
currently.
3 schools, and so I don't want to overemphasize the penetration of that, but we know we'd like to see more of that. And that was something that we've certainly worked through and talked to the provider community about. These are ideas that we have jointly come to.
Right. Okay. All right. So we have 7 schools who are in the charter school pilot. We're open to more. We have 3 schools that are currently doing a hybrid model.
And
We are
we're
open to more
more.
on the high school side.
Correct.
Okay. We don't know how many schools will have to move to sharing a clinician, but that is something that will be worked out
That's correct.
over the next
Mhm.
little bit. All right. Okay. What do you say to the providers and the advocates who say DC government should just cover the whole 89,000 to increase the salaries of the clinicians overall?
Well, first of all, as the model was developed, we entered into an agreement with input from the provider community that this is a way of funding this particular effort. And so that's where we are. In a tight budget circumstance like we are right now, I just would not know where the resources could be found to do that.
Okay. In that growing conversation, for a while, we've been talking about a cost study for school-based behavioral health.
Mhm.
Is that complete? Will that be released?
About a what? A cost of living increase? Is that what you?
No, a cost study for.
Oh, a cost study. Yes, a cost study is currently under review and should be released soon.
What's the definition of soon?
Soon.
Okay. So that, whatever is in that cost study is not what informed the FY25 budget proposal. I'm assuming, I'm taking a guess. If it's under
Well-
review, you didn't use it to build out this budget.
Well, I mean, obviously, we know what's in the proposal. And we have looked at the proposal, and given our current circumstance, we certainly wanted to make sure that we didn't decrease the amount of funding that was available on a per clinician basis. And so that was the determination.
Okay, what I'm trying to get at is, every year, not every year, every couple of years, the Deputy Mayor for Education does an adequacy study.
Mhm.
We've never met any of the targets of the adequacy study ever since we started doing it back in like when I was a staffer, so 2012,
Mhm.
2013, et cetera. But we
Mhm.
still release it because we want to know what our goal is. What should be
Mhm.
our reach of adequate funding levels for the various
Mhm.
pieces that we do for UPSFF. I don't want to see, I'm saying I want to see what the cost study says, regardless of whether our current financial state.
Sure.
So we
Mhm.
kind of know, all right, if we're ever going to get to what we really think the full cost is going to be for an effective program, this is what we
Mhm.
have to reach in terms of the benchmarks.
Okay.
Okay, cool. In terms of the private insurance piece, have you had conversations with Commissioner Karima Woods around how we could better work with insurance companies on this?
We've had one cursory conversation, but we need to do more
Okay.
in terms of that.
So in the pre-hearing responses, you all said that you're including 1.8 million to continue the expansion of school-based behavioral health or school behavioral health services through grants to CBOs in the highest need schools.
Mhm.
Is this 1.8 part of the 28.3 million that's allocated for the program, or is this in addition to?
That's yeah, it's included in it.
Okay, included. All right, and what exactly will this 1.8 fund?
It funds, as you know, one of the things that we looked at is the highest need schools, and it funds a variety of things. In some instances, it might fund additional services and supports. It might fund additional materials for that school, but it's really school driven in terms of what do you need to enhance the behavioral health status of your students. So it varies.
Is it application based?
Huh?
Or, I mean, is it application based, or are you all saying for the
No.
CBOs that are serving X schools, you get
Right.
additional
Th-
funding?
These are the highest need schools based upon the assessment that was done using the Aussie framework. That was developed several years ago, which I'm sure you recognize. And those 25 highest need schools were the ones who got these funds.
Okay. In terms of the 7 charter school, or I'm just gonna refer to it as the charter school pilot and then the hybrid pilot.
Mm-hmm.
When do you all, or how do you all anticipate receiving feedback on whether or not the models worked? Is there
Well-
gonna be a survey at the end of the school year, interviews with the LEAs?
Well, as you know, we do have an evaluator of school-based behavioral health. And we anticipate that evaluator, an evaluation company would assess the efficacy of that program so that we know if that's something that we should continue, expand, or modify.
Okay. The DBH budget chapter narrative in the books that we have from the CFO suggested a decrease of about $700,000 in the community of practice contract for FY25.
Mm-hmm.
However, the budget documents that we all received from you all indicate that the current contractor, George Washington University, will have a $593,780 contract for training and report development. So are we cutting community of practice or no?
Yes, we're cutting the community of practice contract.
Okay, so the 593,000 for George Washington University that's listed on your contract documents that you sent to us is for something separate.
No? No.
Okay,
Mm-mm.
in the is a spreadsheet, right?
No.
So the contract spreadsheet that you all provided to us
Mm-hmm.
in your pre-hearing still lists George Washington University as a contractor for $593,000 for FY25. But you're telling me
that. My understanding, based upon the budget, is that we had to make some reductions, and the community of practice contract was terminated, will be terminated at the end of the year.
okay, so is that $593,000 just floating?
Is it what, just floating?
Floating, available for use? If you're gonna cut the contract, but we have that you all have budgeted for it.
I have to follow up on that.
Okay,
There could be a no-cost extension for the remaining of the funds that are available within the contract, period, if the whole contract hasn't been expended. But our plan is to terminate that contract.
okay. All right, so who would we follow up to see whether or not that's still on your budget? Is that an AFO question, Mr. Reed?
I'll be happy to follow up on that.
Okay, great. Okay, in the pre-hearing responses, you all indicate that a grantee was selected to implement the school-based or school behavioral health peer educator pilot, and that peers will start work this month.
Mhm.
There wasn't funding included for a second year. So is the expectation that the CBO who received this work is supposed to expend all of the funds by the end of the school year?
By the end of September, because this is a fiscal year contract. And actually, I had a conversation with our school-based behavioral health as well as our COO in terms of what are the possibilities and potential opportunities for us to continue that contract into the next fiscal year. And that's something that we are going to look into.
Okay. Is that a reimbursement-based contract?
A reimbursement base, no, it's a reimbursement-based contract?
I like the provider tells you how much they spent and then you reimburse them based and draw down on the grant.
They draw down as they expend the funds, and they do have to submit an invoice for the services that they provide.
Okay, because being that the funds are available to September 30, it does allow for them to start for school year 24-25.
Yes, it ends September 30th.
I know. What I'm
Mhm.
saying is that the bridge is not that much, if that makes sense. If we weren't, if we desire to get this for the full school year 25, school year 24-25, they have funding currently that could get them August and September.
That's correct.
And then we just need to figure out
What to
October.
do? Yeah,
June.
moving forward.
Okay. All right. Let's switch a little bit to talking about the behavioral health carve-in for MCOs or
Mhm.
not.
Mhm.
So I understand that we paused this due to funding.
Mhm.
I'm curious, what was the impact of the pause to DBH's budget calculations and to staff? There were certain things that you all were planning for MCOs now taking on
Mhm.
that they won't be doing, that your staff will be continuing to do. And so did you all have to hold on to staff or budget contracts that you thought you might have had otherwise? Although it seems from the proposed decrease in the access helpline that perhaps that didn't happen all the way through.
Mm-mm. Well, first of all, let me talk about the impact of the carve-in on the Department of Behavioral Health. Essentially, as you know, the carve-in date has moved a couple of times, and so we did have gap period policies in place that allowed us to function effectively until the carve-in occurred. Those gap period policies have been reviewed by my team in partnership with the Department of Healthcare Finance, and so that we can continue for as long as we need to. So it's not that suddenly things will stop.
Okay. The pause obviously impacted providers who have been making preparations in terms of changing systems over around new billing, new conversations, et cetera. Will DBH consider any form of reimbursement for the transition related costs that the providers have incurred?
Well, first of all, let me say and be clear that this whole effort for the past 2.5 years have had two components. One component was really transformation of the behavioral healthcare system to increase quality of care. That is why a number of things were put in place with the providers. That included things like enhancing their HIE systems. It included putting in place requirements for a national accreditation, which they have achieved. It included things like a lot of things that were strengthening the provider network. Those things continue on. Those are a part of the overall transformation effort. They also, for example, we have instituted a process where the providers will have to provide NPI numbers for all of their staff so that we can know who is billing for what. They have to have bidirectional interaction with CRISP so that they can look into the system and see the whole person care effort, as well as put information into the system. All of this really is designed to support whole person care. So those things are things that have been done. So there really is no cost that should be reimbursed to providers. We have upgraded the system. Many of our providers, by the way, prior to this were already paneled with the MCOs. Many more have been paneled since, and those that are paneled will be able to build the MCOs.
Okay. All right. Let's talk a little bit about the Stabilization Center. It was really great to have Mr. Hogboom there yesterday, who is the CEO of Community Bridges. How much funding is there in the FY20 budget for the second location?
For
The
the
Stabilization Center.
second stabilization center, DBH received in the FY24 budget $9.5 million for the build and design of the second center.
Okay. And were there no capital funds for FY25? Are we just assuming that 9.4 is enough and then
Capital.
there's carryover?
Yeah.
Okay. In terms of, does the budget you all have though include money for the contract for operations of a second center for
No.
FY25?
It does not.
It does not.
Okay. How much is the existing contract for operations at K Street?
Yeah, 4.8, and depending on the number of months in FY25 that would need to be open. I mean, if it were 3 months, it would be 1.2 million. If it were 4 months, 1.8.
Okay. So here's my news to me. probably news to Councilmember Nadeau in Ward 1. So we're spending money to build a building and then we have no money to operate it. That's what y'all saying.
There are no operating funds.
There are no
There are no
operating funds.
operating funds within the budget. And based upon the design and build contract and what DGS is telling us, it appears that the building, requires a lot of modifications, as
Mhm.
you know, because
It was a
it's an
firehouse.
It's an old historic building.
Yep.
From the 1900s, and it is estimated that at the earliest, it probably would not be ready until somewhere in quarter 4 of the fiscal year, and it could be later than that.
Oh, okay. So we're looking at a 2026
Right,
opening. Okay.
right.
All right. That gives me less. Heart
Yeah.
palpitations.
So,
All right. Okay. Yesterday, we heard testimony from a couple of providers around the need for a behavioral health urgent care model in the district, which is
Mhm.
distinct from CPAP. Are you familiar with this proposal, or was yesterday the first time that you were hearing about it?
Well, we have been, actually, Dr. Bebout, who is our Director of Crisis Services, has been looking into that. And we really are trying to determine, the difference between that and our current CPAP model, and whether or not, the CPAP model, as it moves to, more of a broader framework could be used for a similar purpose, but we're still exploring that.
Okay. Well, I think one of the distinctions from CPAP doesn't have a location where a person can go if they are, I'm hearing voices, I'm feeling
Well-
like I might harm myself, as opposed to just going straight to the emergency room.
Well, quite frankly, there are individuals who do walk into CPAP. In addition to those that are taken there by fire and emergency medical services and the MPD. And so, in fact, people do walk in if they need it. And then also remember, we also have our urgent care clinic at 35 K Street, where people can get just in time, same day services.
Okay. Okay, so you brought up 35 K Street. We are seeing on the budget some proposed reductions at 35 K Street
Mhm,
in the adult clinical services.
mhm.
Would that not impact capacity for CPAP, or is that for a different program?
No, it will not impact CPAP, certainly not. And essentially what we did here again is we looked at the utilization of 35 K Street and looked at what the structure needed to be able to continue to provide the level of service. The other thing to note is that many of the providers that are there are Medicatable. I shouldn't say that, but their salaries are paid by Medicaid as opposed to local dollars. And so we're really looking at
Mhm.
the combination of funding opportunities to support that.
Right, but so I have a group who's saying we need a location for behavioral health urgent care services. You're
Mhm.
telling me, nope, CPAP's got it, but you're also saying, well, we're reducing
Mhm.
services at
No.
or we're reducing something, because I see a
Mhm.
$725,000 cut. So something is being reduced
Mhm.
at the location where folks can just walk in. Is it perhaps that our CPAP?
Well, and then I do want to say that, no, we're not reducing, and I don't think that we will be unable to provide the urgent care clinic. I do think what you see in that line is that there is the IDD program there,
I'm sorry, say
the
that.
Individuals with Developmental Disabilities program there.
Okay.
And that program serves about 148 people. However, Those services are also available within the community through our provider network. And so one of the things to do that we'd like to do is to move and plan to do is move that program into the community. And that really represents the bulk of those costs.
Okay. All right. So just to sort of close out on the conversation about the urgent care piece of things, I think there, at least to me, the way that it's sort of described, there might be synergies with programs that are already existing that just need retooling. I don't know how many people know that they can walk into CPAP. It's not on a website that says, hey, if you need immediate services, you can come here. Obviously, for MPD and FEMS, they are aware of these
Mhm.
things, but I think what folks are envisioning is a very much like a adult or pediatric urgent care where it's open from, X time to X time. And then people, you could have an appointment, but you don't need an appointment. To sort of reduce the number of individuals who are going into the emergency rooms.
Yeah,
You know.
and I think here again, as I said, that's something to be explored. Dr. Bebout is looking
Okay.
at how that service might be put in place. But we don't have enough information right now in terms of a model.
Okay. All right. I think Dr. Canavan yesterday said the
Right.
empath model.
Empath model. We've looked at the empath model. And if you look at that, and I have looked at that,
Okay.
it looks very much like a CPAP.
Okay. All right. Well, we could talk more about that.
Yeah.
There's no money to do that today.
That's right, but it's
So,
very much like a CPAP based on what I saw online.
okay.
Okay.
All right. So let's talk a little bit about opioids then. In terms of what I have gleaned from the numbers of the number of individuals who've been at the stabilization center, the vast majority of those clients have been there for alcohol related interventions as opposed to opioid related interventions. Was this something that you all were anticipating?
Yes, as a matter of fact, we used the FEMS data and the Fire and Emergency Medical Services data to really look at what the population looks like because we wanted to make sure that we diverted individuals from emergency rooms. So we wanted to look at what that population looked like, and we wanted to work with them to get them into recovery. And so we knew what that breakdown was going to look like, but we knew and quite frankly, it's very similar to what I learned when I went out to San Francisco and looked at their center, when I went out to see the CBI centers in Arizona. There is that mix. And here again, the point is that whoever is using, be it alcohol or whatever substance, have a place where they can go to recover and stabilize, and they can be connected to a peer that can then get them into service. And here again, it has multiple positive effects. One, it reduces the emergency room clog. And two, and more importantly, it really provides the necessary services and supports for those individuals.
Yeah. Okay. I do think it's great in terms of I don't want someone taking.
You were there.
Yeah. I don't want someone to take an emergency room bed or bay because you are coming down off of alcohol, those types of things, right? So I think it's good in sort of diverting that kind of attention. But given our opioid situation that we're having, it's a little disappointing that we're not necessarily seeing similar or equal numbers on that front. And so obviously that just shows that we still have a lot more work to do.
Well, and I think too, remember, and we do have multiple outreach teams out there in the community
Mhm.
working directly with individuals who are actively using. And one of the things that we know is that, making that decision to move into recovery is a journey.
Yeah.
And so we have to really work with people and meet them where they are. We have a harm reduction philosophy that we follow, and we are implementing that. And hopefully, as our engagement strategies take hold, we may see more people at the center, or just going into treatment.
Okay. The budget chapter for DBH combines Live Long DC and the state opioid response in terms of funding, or it's listed as one together. Can you provide a breakdown of the two? How much are you all receiving in funds for state opioid response versus how much is a local investment for Live Long DC?
You gonna take that? Okay. Just give me 1 second and I will give you the numbers.
You could phone a friend, the AFO.
So the DBH was approved for a restructuring. So the name for Live Long DC and State Opioid Response was combined for the updated name, which was formerly the accounting codes that housed the SOAR grants. So
Okay.
it's predominantly federal funding for that program.
Okay, so that's helpful. All right, so for folks who are watching, we have a new financial management system, CFO's office called diffs, and there were some adjustments that were made. All right, so the new line for state opioid response and Live Long DC is one together.
Yes,
All right, so then my question, I'm seeing 36 million. Is that accurate?
that is accurate.
All
That's inclusive of the state opioid response grants that we get on an annual basis and any projected carryover that we may have.
Okay, so how much of the 36 million is federal?
All of it.
All right. So what is our local investment in opioid?
You mean, well, I think that first of all, the Stabilization Center has local money there.
Okay,
And so that's a part of the investment. And then in addition, in terms of opioids, the full range of services and supports that we offer through our SUD provider network certainly is a piece of it. We pay, as you know, the 30% match for that. And so that is a part of that investment. We also have some grant activities
mhm,
that are supported. And then I think you're well aware of the fact that in addition, as the Opioid Abatement Advisory Council has been stood up, we also are using those funds to invest in substance use disorders.
okay. Of the 36 that's listed, how much of that is projected, or how much of that is projected as new?
There is 30 million that's projected as new.
Okay. So 6 million is projected carryover.
Yes.
Okay,
And that number may change, obviously, it's a projection, so it may change, but we rather estimate a projection so that we can start spending the funds on October 1st, as soon as the budget is approved or when the grantor approves the carryover request.
okay, great. All right,
Mhm.
so in the pre-hearing responses, it details the allocation of carryover funds requested from DBH from SAMHSA for fiscal years 22 and 23.
Mhm.
So for instance, the grant for DC-City, changing and improving treatment for our youth. It concluded March 31st of 2024. You all have 93,000 that's recorded in the progress on spending, so funds spent, out of the 268,000. So this presents a little confusion. So was the entire grant amount utilized, or was only 93,000 utilized from that grant?
And we're talking about a city grant, not the opioid response. We moved on to DC City, right?
Yeah, DC
Okay.
City.
Can I ask you to if I can follow up on that?
Sure.
Mhm.
So this was in the pre-hearing responses. That's where we're getting our information from. Okay. We've been joined by Councilmember Brianna Nadeau from Ward 1. I'm going to give you a couple of minutes to settle. Okay. And then we'll wrap up on this. Okay, so Dr. Bazran, the proposed budget, we know from Mr. Reed for what we're gonna call state opioid response / live long DC is 36 million. However, in the information, when we asked you all for what's the spend plan for this, you didn't have one. You all
For
said
FY
that was,
25?
I'm sorry?
For FY 25?
Yes,
Okay, I can address that,
okay.
okay?
Or I don't need the addressing of why you don't have one. I just want to know what you're planning to spend it on. That's really what the goal is. My
Mhm,
question is, what
mhm.
is the spend plan? What is our plan for the 36?
Well, I think that there are a number of efforts that we currently have underway in terms of our grants. I can certainly give you that. Many of them are continuations. And so we would certainly use it for that. The other thing to note is that youth SUD services is one of our priorities. And so we would certainly want to spend dollars on that. We would continue our outreach activities, our harm reduction activities, our prevention activities, and so forth. One of the reasons we don't have a spend plan for FY 25 is because SAMHSA has not yet given us the grant application that we can complete that includes the spending plan.
Okay,
It hasn't dropped yet.
okay. The struggle that I have on my side is I know that there are some of our, hold on, if you could turn your mic off. And you turn, yeah, yeah, too many mics on.
Mhm.
The struggle that I have is that I have agencies that are within our, let's say, substance use ecosystem
Mhm.
who are losing grants that are opioid related, who probably could use some of your money to fill in on some of that. But I don't know whether or not I should tell them to talk to you about it. So
Oh, certainly.
for example, what's today? Today's Thursday. I'm not entirely sure when this hearing was, but for Office of the Chief Medical Examiner, I don't remember what day of the week, and I'm not even gonna try. It happened prior. They are losing some grants that are related to like testing syringes that are related to our opioid surveillance. Those grants are expiring. And they could use your money, I think, or at least not, if not you, use the opioid
could.
abatement fund money to sort of fill in some of those grants, because that's at least as it was explained by Dr. Diaz's team, this is the folks that collect the syringes and then they test for the cornucopia of drugs to see what's happening, what's on the street, what's in the community. I think that's an important thing that we need to continue. But instead of us finding new local dollars for that, I feel like that fits in the allowable uses of SOAR or the opioid abatement, et cetera. But I don't know what your plans are. So that's why I'm trying to, when is the appropriate time for you all to have those conversations? Or if you wanted to do some funding to OCME or to FEMS for some of their opioid activities, that can get into the plan for SAMHSA.
Well, first of all, we do meet with the other directors and other members of government to talk about what we need to do moving forward with our state opioid response program. And so certainly, OCME can certainly reach out and we can have that discussion
Okay.
sooner rather than later.
May I just take a moment to explain
You
response?
just got, you have to, the folks are saying you are a light talker.
I am. I apologize.
Just lean into the
Um,
mic.
So if I may explain the formatting on response to 12, which was the carryover that you just asked about.
Oh, yes,
um,
yes. I have the chart, so I was gonna bring that to Mr. Reed, but go ahead.
Okay, so the way it's laid out is the amount of carryover is what we've been approved for. And the next column is how much of that have we spent?
Mhm.
So particularly of the 268,197, we have to date spent 93,129, and we anticipate exhausting it by the end of the carryover period. On the two last items listed, we just received carryover and we have not spent that. We anticipate spending it. It's kind of weird. The end of the carryover period is not aligned with the fiscal year. There's one day less. So
Okay.
it's 9/29, and that's why that looks a little different.
Okay. Let's say the amount of carryover that you've been approved for FY 22 does not get expended. Does SAMHSA give you an opportunity to carry it over again?
Sometimes.
Mhm.
Sometimes.
Yes.
Okay.
Mhm.
All right. Great. Thank you.
We would apply for that.
Okay. Councilmember Nadeau?
Thank you, Madam Chair, and thank you for asking already so many questions that I know we both are interested in, so I won't have to belabor this with so much going on today. Dr. Bazran, good to see you. So I am concerned about the lack of funding for targeted substance use outreach across Ward 1. You know, I have funded these grants each year, and this is the first year it's with DBH, moving it over from DSLBD, but that Community Navigator program, you know, in the heart of Columbia Heights, but also now having expanded it across the ward. In the public testimony, we heard about how critical this community-based work has been. I'm concerned about how ending this program will impact all of our efforts in community and ask, what's your plan to continue this important work without that funding?
At this point, unfortunately, we do not have funding for that effort in our FY 25 budget. The 3 outreach programs in Wards 1, 5, and 7 were included at $200,000 each for a total of $600,000.
Thank you for continuing those programs. I do appreciate it. Of course, our program in Ward 1, I think, was close to $800,000 itself.
Yeah.
And so, and I know that in the oversight hearing this year, you noted this program had a tremendous amount of impact. And I think we were all hoping to figure out how to make it integrated into DBH rather than just something that I fund each year. Is there anywhere that it would fit as a permanent program if the funding was available?
I don't know. I do know it was one-time funding last year. As you
Right.
remember, I worked very closely with you
Yes.
on that. And with the slim budget that we have this year and the budget pressures, I am not sure. However, I would imagine that it might be something for consideration for either opioid abatement or one of the other funds, but I can't say for sure at this moment.
We'll definitely look forward to hearing more about the plans for those funds as the chair was talking about. Are you concerned? I'm concerned about how DBH is going to operate the Columbia Heights Stabilization Center without these experienced outreach workers who sort of built that ecosystem in the neighborhood and really bring people in to that space who are so eager to connect folks there. How do you think we're going to be able to do that outreach to get people to the center in Columbia Heights?
Well, certainly, the existing outreach teams that we have, as you know, we do have outreach teams, with HIPS, family medical and others. And certainly those outreach teams, do, circulate as well as the DBH team through, that ward. And so, it's not that there is no, interaction or coverage. And so those things would be continued. The other thing, you know, certainly as we begin our planning process, we do want to plan with the community around how this particular center will operate.
Do we have a date for the community meeting coming up?
I think it's sometimes in April 25th is when I think it is. Is that correct? Yeah, it was my recollection.
Have we heard back from DGS on whether or not they'll be able to participate on that date?
No, I have not heard back from them.
You may remember when you came on as director this time that I had been asking annually for reports on the DBH outreach in Columbia Heights and other parts of the ward. Because despite the very hard work of the DBH team, they're stretched very thin. And I know that we still have trouble filling all the funded positions.
Mhm.
And it really felt to me year after year that we just weren't making enough progress for the people suffering from substance use disorder in Columbia Heights, U Street, et cetera, which is why I established the Community Navigator program.
Mhm.
How do we know that we won't go back to that situation where there's just not enough daily touch to actually get people to make that leap to go to a stabilization center or other treatment?
Council member, I cannot, respond in terms of, what might happen. I can only share with you that we will use the existing resources we have to the best of our ability. That was, an event that was an activity that was, unfortunately, one-time funding. And in this slim budget year, we just don't have the resources to replace it.
I understand, and honestly,
I
was
mean, we just
surprised you
don't.
didn't lead with the one-time funding line because that's
Yeah, we
classic.
just-
But
yeah. No, well, I mean. no,
I
it-
appreciate you trying to give a better answer than it
Yeah.
was one-time funding. But I guess I'm just wondering how you're thinking about
Mhm.
the way you fill that gap, right? We had a resource, we're losing the resource, the need is still there.
Mhm.
Surely the opioid fund can't fill in every gap.
No, absolutely not.
So what's the answer? Is the answer that we're just not going to get to everybody?
Well, I think that one of the things that we've been talking with our outreach teams about, which is, how do we provide coverage for the entire district? And one of the issues has been um, when a team is just dedicated in one area, we can't go necessarily freely to the other areas where the need might be. And so I think that we have to really look at that model also in terms of how we can best meet the needs of our residents.
Yeah, I mean, I think it's
So
a
that's another pull and tug.
yeah, it's a question, right? So it's like a resource that's maybe not as well resourced that goes everywhere, or a dedicated place-based resource that we know is going to be there in an area that there's high need. I mean, that's the constant pull and tug of all resources in district government,
Mhm.
right? So let's talk about the stabilization center for a little while longer. I am concerned by the news that it won't open until Q4 of FY25 when it was originally Q2. Can you share more details about what's led to the new timeline?
Well, certainly. And then I will ask Mr. Neff also, who has been working very closely with DGS. But essentially, we can't open the center until the building is ready. And there are multiple issues, mold. I mean, it was a building that was built in the early 1900s, and it has to be safe for occupancy. And we know that there are other issues that we have to deal with. It's 2 floors.
Mhm.
And so we have to look at, elevator installations and so forth. And all of these things take a lot of time. I think we'll know more as the building and design contract is actually awarded, and we meet with the provider, and I'll ask Mr. Neff to add anything.
The design and build contract closed
Mhm.
last Friday, Friday the 5th. It'll take some time for OCP to go through all of the responses. Design and build solicitations are huge.
Yep. Do you know how many responses there were?
I do not. I think they really have to make sure that everybody was in compliance. I think that's the first, and make sure that all of the addendums that were required, and I've actually not seen one this large, because it has to have all sorts of structural things and, subcontractor for supplies and that. So I think it's going to take probably a few weeks before that's known. And then the review of the TAP technical evaluation panel will begin, and I'm on that panel.
Okay. And I heard Councilmember Henderson earlier ask about the operating funds. So how are we going to open it in FY25 with no operating funds?
There are no operating funds in our FY25 budget. Based on the needs for the build out, it's just very doubtful that it would open within the fiscal year.
So it's not even going to open in Q4 FY25?
Correct. And if it does, it'll be at the very, probably in the fourth quarter. That's what I've been told.
Okay. Thank you, Madam Chair.
Councilmember Ditto, if you had some. Okay, all right. Okay. All right. Sort of, I just want to follow up on one thing because I forgot that is actually in my notes. So, when I was referring to the Office of the Chief Medical Examiner, I just want to tell you specifically what they're losing. So, it's 506,000 for the forensic toxicology lab services. So like I said, it's the lab that tests what's in things. And then 247,000 for their data fusion center. And the data fusion center provided critical data on opiate presence in deceased individuals and facilitated information about sharing the scope of the opioid epidemic. So they've been basically the funding that they've been using for the opioid surveillance program gone. And so I just feel like there are funds and other pockets of money that are available that I think these most certainly align to. In terms of Live Long DC 3.0, when are we getting it? Don't tell me soon, because you said soon at Performance Oversight.
What did you say?
When is it being released?
Oh, 3.0, it should be released. Isn't that's on the website, isn't it? It's on the website.
Oh,
now.
there was no fanfare
Yeah.
or a
it's on the
link.
website.
Or a press release.
Yeah, there was a press release, but certainly we can get that to you.
Hey,
Okay?
released. Wonderful. Okay. That's good. I mean, you guys said in October it was supposed to be released, so
It's released.
good to have it in April. All right. Let's talk about the Office of Opioid Abatement, Office of Opioid Abatement Settlement Funds. Dr. Bazarine, you know this is I'm never going to vote for a 21-person task force for anything ever. I've already told my colleagues this. I will vote no every time. I don't care if it is the most wonderful situation, simply because it makes it so difficult to have conversations and to actually get to a decision-making process. I think one of the things that has been a challenge, though, is around the strength of the opioid abatement office and sort of directing the activities of the commission to say, here is the meeting schedule. This is when we are going to ask for funds available, et cetera. And then also relatedly, transparency on the back end in terms of this is what monies have been spent towards based on the recommendations from the committee.
Mm-hmm.
How do you all envision determining what's the difference between what is spent from opioid abatement funds versus what's spent on state opioid response funds?
First of all, I think, council member, you may recall that during the initial meetings of the Opioid Abatement Advisory Council, we provided information to the group in terms of what the expenditures were and the areas of expenditure from the state opioid response grant. And what we don't want to do is duplicate that activity. As those recommendations came in from the advisory, we actually looked at those recommendations to determine whether or not there was something that was very similar or the same that was being funded through the state opioid response grant through Live Long DC. In one instance, for example, I can give you an example. There was a request and a recommendation to fund additional vending machines. Well, vending machines are already being funded through the SOAR grant. And so we took that off the table because we want to use the funds in the best way possible. So we want to use these funds to fund things like the youth treatment program at Children's Hospital
Mhm.
that is not being funded by the state opioid response grant. And so we really looked very carefully at those areas.
Okay. What is envisioned for the regular cadence of meetings for the
I'm
commission?
sorry.
What is envisioned for a cadence of meetings of the commission? I don't think the
As
next
you
meeting
know-
has been scheduled.
Oh, I'm sorry. I didn't mean to interrupt you.
Okay.
As you know, in the legislation, we are to meet quarterly, and we certainly will meet that obligation.
Have there been any additional contracts or funds expended since the initial
Yes.
funding for the communications plan?
Yes, and I can certainly submit to you a list of those contracts.
Okay,
Okay.
that'd be great. Okay, St. Elizabeth's. Let's talk about St. Elizabeth's. The budget chapter reflects increases for several line items, including 1.7 million for clinical and medical services, 4.5 million for hospital administrative services, 3.9 million for nursing services. Is most of this contributed to CBAs and overtime?
Yes, most of it is.
Okay. Beyond CBAs and overtime, is there another area that is accounted for that we don't know of?
Yes, so actually, some of it is an increase for the salary and fringe adjustments for the amount of staff that we have at the hospital.
Okay. I guess what I'm trying to get at is, there's no launching of a new program or something within the services.
No.
No, okay. All right, so, following up on yesterday's testimony regarding, concerns about DBH, about cuts to DBH's accountability division, specifically the decision to discontinue some independent investigations at St. Elizabeth's Hospital, I have some questions. So which department is responsible for conducting independent investigations at St. Elizabeth's Hospital?
It depends on the incident.
You're gonna have to come closer since you have your mic on, just.
Yes, test. can
Or
you hear
sorry,
me?
since you have your mask on.
Yes, can you hear me clearly?
Yes.
Thank you. So internal matters are investigated by a department within the hospital. So the police from time to time may investigate crimes, internal investigation, external investigation, depending on the incident.
Okay. Has the budget for independent investigations actually been reduced in the FY 25 budget compared to previous years?
No.
Okay. All right. Okay. Just a couple of questions on ARPA funding. So the pre-hearing responses for DBH included a spend plan for the remaining ARPA funds for FY 24. Are any of these funds anticipated to carry over or remain eligible for use in FY 25?
No, they don't. They'll expire.
All right. In terms of the ARPA spend plan, you all had something named the DBH Educator Mental Health Program. It was allocated for $293,000. What was that program?
The DBH what? I'm sorry.
DBH Educator Mental Health Program. It was in your
Oh,
ARPA.
okay. I can tell you what it was. If you remember during COVID, We did provide some trauma support and other supports to educators within the school setting, and that's what that was for. Similar to what we did with the
Mhm.
parents.
Okay. When, let me ask you this, so folks don't think that that would no longer be applied, because I know that you guys do this, but if there is a particular situation that happens at a school that is trauma related or otherwise, you all still, without this money, have the capacity to
Absolutely.
deploy individuals to a school.
Actually, yes, and that what we have done is that has become a part of our crisis continuum. And we do have people with expertise in addressing child-related trauma experiences, and particularly those within the schools. The schools invite our clinicians in, and we provide those services, and that's ongoing. That has not changed.
Okay. All right. Speaking of teachers and educators, let's talk a little bit about child, adolescent, family services. The proposed budget shows a significant funding reduction of about 568,000 within the court assessment services line. Now, the crosswalk that you all provided indicated that this reduction was due to a program modification. What was the program modification?
In the court assessment,
Yes, but for under
I can tell you what. it
under
is.
child,
Yes, I-
adolescent,
yes,
family services.
certainly.
Okay.
We have an assessment center that was formerly located in the Moultrie Building, which now has been relocated to 821 Howard Road. We provide assessments for individuals that are court involved in the family court system. And we do that through contracted arrangements with mental health professionals, psychiatrists, and psychologists. We did reduce the amount there. It was basically looking at how we could streamline the service. Last year, we actually conducted a number of the psychiatric services using our in-house psychiatrists as opposed to consultants. We found that some of the contracts that we had let were not even utilized because we couldn't find the technical staff to actually implement them. So we did them in-house. You know, our own psychiatrist did them, and we plan to do that again. So we do not envision that there's going to be a decrease in the services that are provided to support those young people and their families. And they are now in a wonderful facility. They're very happy being at Howard Road. They're in Ward 8 on the second floor of that facility. Own private interests, own parking lot.
Okay. All right. So the reduction is a reflection of us going from contract based to now in-house work,
To support in-house supports, yes.
in-house supports. Okay. All right. Healthy Futures. Do we propose any funding cuts for Healthy Futures? Was additional funding needed for the Healthy Futures evaluation?
Not at this time.
Okay, so the pre-hearing responses included an ARPA funding spend plan that included Healthy Futures expansion. With the expiration of the ARPA funds at FY '24, are we still expanding Healthy Futures
Well,
or?
we have to utilize the funds that we have, obviously,
Right,
and we'll do as much as we can with those.
okay, so what will happen once those funds are expended to the expansion?
Well, my understanding is are you talking about the ARPA funds that were used to support
The expansion,
treatment?
yep.
It was treatment services,
Mhm.
as I believe it. And here again, we'll have to look at how we can provide those with our existing clinical staff.
Okay. All right. take notes for me to remember. At the performance oversight hearing in January, DBH announced that it would begin development of a strategic plan for children's behavioral health. Is there any additional funding that is required for this initiative in FY25?
I don't know the answer to that. We do want to certainly develop the plan, and we would use existing resources to fund that.
Okay. Right. So we heard quite a bit of testimony yesterday about the reduction of about 922,000 from the court urgent care clinic. The pre-hearing responses indicated that the discontinuation of the clinic was due to the requirement that all SUD providers conduct intake and referrals and low utilization. However, yesterday Pathways, reported an increase in client utilization since the return to in-person hearings at the courthouse in FY24. So were you all, when you talked about low utilization, were you looking at current year FY24, or were you looking at FY22 and FY23, which were low, but at the time, the courthouse had minimal in-person hearings taking place. Now they're back to almost full strength at this point.
Right. Well, actually, we collected data on FY23 and FY24, and I'll give you some key examples of what the data looks like. If you look at, and I'm going to pick high months in FY23, at the height in August, there were a total of 49 individuals seen in a month. Okay. If you go to FY24, and here again, I'm picking high months, high utilization months. In January, there were 59 people seen in a 31-day period. In March, there were 78. And so that's about 2 to 3 people a day, which is really minimal in terms of the amount of funding that we have. I do want to share that the goal and the objectives for this particular center was to conduct assessments of the individuals who come in, to de-escalate behaviors as needed. And we have 5 staff there, which includes a psychiatrist, 2 LICSWs, 1 CAC, and 1 intake worker / program assistant. And quite frankly, the utilization that we see is just low and can't support that.
Right. So, the data that Pathways provided us is that they've had 315 clients so far this fiscal year.
Well, but I think you got to look at, to do what? Because our contract is very specific about what the requirements are. It is not a core service agency. Those are not the services that are there. This really is urgent care, providing an assessment. If the individual needs to be connected to a core service agency, you can either, if they're SUD, you can literally call and have them taken there. If it's mental health, you can call and have them connected so that they can get those services within the community. If you look at the data that they provided, they have, housing assessment referrals and continuing care. It is not designed to be continuing care for individuals. That is not the design. And I can tell you, I actually wrote this, the RFP for this program when I was here the first time around. And that was the purpose of it. And that's what the court expected.
Okay. Did you all inform DC Superior Court of your intention?
Absolutely. I talked to them before the budget, during budget formulation. I spoke to Judge Isco about any impacts that would be on the court as a result of our budget formulation process. He indicated that the court was really concerned about making sure that the assessment center services were in place and could move forward. but we did not get that feedback on the urgent care clinic. I had formally talked to the chief judge about the low utilization in the urgent care clinic and had said to her that at some point, I wasn't sure whether we could really afford to continue that.
Okay,
I have then followed up again with Judge Isco, and he, kind of understands the decision-making process.
okay. So is the intention that we will continue assessment services, but it is just the clinic portion that is closing?
No, the urgent care clinic will close.
I know that's what I said.
Oh, okay.
Isn't that what?
Oh, you meant like the child services. I'm sorry.
Yeah.
Okay. The
Yeah.
child services will
Yes.
continue. The urgent care clinic will close. Yes, ma'am.
Okay, okay. So going forward, if there's something that happens at the courthouse, they will have to essentially call out.
Well, also remember CSOSA is also there, and they also provide services to the court. And the other thing is if there is a crisis and they need to deploy a crisis team, they could certainly do that.
Okay. The 5 staff that are there, those are technically pathway staff?
Those are pathway staff. Those are contracted employees.
Okay. Let's talk a little bit about housing and residential support. So the proposed budget for 25 allocates 28.9 million to housing, residential support and continuity of services, which reflects about a $650,000 reduction from the previous year. Is it possible for you all to break down how much of this funding is going to what? Because when you put it all together, how much is actual housing? How much of it is the services piece? Are there vouchers included?
Adrian?
Yes, we can provide you with a detailed analysis if we can follow up on that.
Can you just say if our housing vouchers included?
I'm sorry, I'm having trouble.
Are
hearing.
housing vouchers included?
Yes, housing vouchers are included.
Okay. All right. The grant for extensive housing case management, is that also included in this bucket?
Mhm. Yes.
Okay. All right. So we'll ask for a follow-up. We
Yes.
want a detailed sprint,
And we'll send you the details.
a
Mhm.
breakout of that. Okay. During yesterday's public hearing testimony, we heard from a mental health community residential facility operator. They mentioned receiving a rate increase this year after a 6-year gap. So thank you for that. Is the rate increase for MHCRFs implemented that you are implementing in 24, the funding in the budget is there for it to continue in FY 25?
Correct.
Okay. We also heard a witness testify yesterday about the change in the P&A, the personal needs allowance for MHCRF residents from $100 to $134, starting in January 24, with some COLA adjustments for
Mhm.
plan for future years. I'm not sure if I bring this to you
That's
or
a
to
DHCF.
or
yeah.
to healthcare finance.
Healthcare finance.
But essentially what she was trying to get at is who is responsible for informing folks that this increase is available to them?
Mhm.
Is it you or is it healthcare finance?
It's a healthcare finance activity.
Okay. Okay. Okay, so with the behavioral health carbon currently on hold, what's the plan future for Access Helpline?
Access Helpline will certainly continue its work. You can call Access Helpline if you need crisis services. That is still certainly very much a part and it's really core to the business. We have looked at For example, where authorization should occur within the agencies. That's a part of this gap plan that I was telling you about. And so, for example, Access Helpline used to actually provide authorizations for things like evidence-based practices, and now the organizational entity responsible for having oversight for that will provide the access for and the authorization for that particular service. ACT. Now the ACT team actually will provide that oversight service, but Access Helpline will continue its work to respond to crisis circumstances and deploy people appropriately.
Okay. I think the proposed budget proposes a reduction at Access Helpline. Do we feel like that was going to impact current capacity, or are there going to be modifications?
Actually, in terms of, there is not really a reduction. I think that those staff will be picked up with a special grant that we've gotten from 988.
Okay.
I think that's correct.
That is correct.
Okay.
Some of the reduction was attributed to the ARPA funds expiring, but some of that funding has been restored. In addition, we had a great meeting with SAMHSA recently, and we found out that we would be getting funding in fiscal years 25, 26, and throughout for Access Helpline funding.
Okay. All right. It seems as though the CHAMPS contract for FY24 appears to have level funding, but moved to a different cost center.
That's correct.
All right. Are we maintaining the contract with Catholic Charities, or are you rebidding this
Yes.
contract? Okay. Any conversations to going back to a 24-hour service?
Well, yes, essentially that was one of the reasons why CHAMPS was moved under Dr. Bebout in terms of the crisis continuum, was so in fact 24/7 services would be available for families who needed that.
Okay.
And one of the things I would like to share is that we have created a new position, our Director of Children's Crisis and Community Trauma Response within that crisis services team, so that those specialty services will still be available.
But speaking of the CRT, even though you're saying you moved the CHAMPS under in order to have the full continuum, the proposed budget reflects about a $662,000 decrease in the CRT team. The budget narrative indicates that local funding will replace expiring ARPA funds, but we don't necessarily see that reflected.
Yes, quite frankly, if you, what we have is that the budget does continue to fund the expanded crisis services continuum. There were 72 FTEs in FY24 and 73 in FY25. And so it's an addition of 1 FTE. Also, it's noted that some of the clinicians, the 54 clinicians that were ARPA funded, 48 of those were moved to local dollars.
Okay. How many vacancies do we currently have in the CRT team?
About 15. I'll say 12, but went up, yeah.
And are those in active recruitment?
Yes, absolutely.
Is there any funding for retention or recruitment bonuses in the FY25 budget for the
No.
CRT? Was that considered?
We would certainly love to have had it, but here again, it's a very tight budget year. And so we really focused on core services.
I understand that, and
Yeah.
I appreciate the core services, but when I think of the continuum of individuals who respond to calls 24/7, I got MPD, I got 911, I got CRT, I got FIMS. FEMS and MPD, they have CBAs. MPD's getting hiring and retention bonuses. 911 is paid hourly and they're not getting anything. So it just like, I want to make sure you have good quality people because your CRT people can very well go work at one of these other agencies and probably make more money
Mm-hmm.
in a less stressful environment than what they face from a CRT perspective. And so if we are going to sort of balance it all out, I just want to make sure you all have the resources to be able to recruit the good personnel and keep them after you've trained them, keep them.
Sure, well, we don't have bonus funds in our budget.
Okay. Are there any errors or inconsistencies that you all have noted in your budget chapters that we are going to need to fix?
So I've been able to review the budget chapter, and there are some things that I'm in discussion about that would need to be updated.
Okay, all right. Yeah, we need a detailed list of those when you have them so that we can make the appropriate modifications. I want things to be loaded in the proper lines. It makes it much easier come the beginning of the fiscal year that we don't have to do some large reprogramming in order for you to be able to access funds appropriately. So as you guys can get that to us, we can get that to the council's budget office to make those up. I will say if any of your corrections require additional funding, I hope that whenever you send over, identifies where that additional funding should come from. We had that happen in DGS where they were like, oh no, that wasn't supposed to be cut. It was like, okay, well, that's $2 million. Y'all have it someplace else that we need to find. So yes. Okay. Let's talk about the BSA subtitle. It's called Non-Lapsing Fund Transfers Act of 2024, which grants the CFO the authority to transfer unexpended balances from special purpose dedicated tax and segregated local funds into the general fund's unassigned fund balance. This includes a proposal that includes transferring 2.5 million designated for agreements with independent agencies and 172,460 allocated for gambling, addiction, and treatment research programs. Let's start with the gambling addiction treatment. You know, we've had people testify before about wanting us to expend those funds. I think we put this fund in place when we expanded gambling and sports betting.
Mhm.
You know, have you all been doing treatment and research?
Yes, absolutely. And it's now, gambling addiction services are Medicaid funded. And we do have providers who are actually billing for gambling. We did do extensive training of our providers with the funds that we had, so that they would have and know what the best practices are on gambling addiction services.
Okay, so the loss of funds, how would that impact you?
Not at all.
All right. What about the 2.5 million designated for agreements with independent agencies?
We're in discussion about that fund. A part of it is the cash flows when the cash comes in. So if the cash comes in near the end of the fiscal year, then we don't have the opportunity to increase the budget authority as rapidly and execute a spending plan. So we are in discussion on how we may be able to use that amount this year if we are projecting that amount of revenue.
Okay. All right. The proposed FY25 budget includes a line item for Centers of Excellence Services. It's funded at about $1 million. When did you guys get a Center of Excellence?
Is-
Go ahead.
Excuse me, the Center of Excellence was an update to the proposed FY25 restructuring for DBH.
Okay, but what is it?
It's our training institute.
Say more.
Yes. Well, we provide a range of training opportunities for people within the community, for our clinicians and so forth. In addition to that, we also have our data collection in there, our applied research and evaluation in that particular area, and policy issues,
Okay.
policy supports.
So, Mr. Reed, when you said that it was a reflection of the new or renaming, I guess, are you saying that this isn't technically new?
No,
It's
It-
not new and
it's
it's not
just-
diffs related.
Okay, it's just a renaming.
Yes.
it's a rename.
yes.
Okay.
Yes.
All right. This might also be a diffs, but we see a $6.4 million reduction in the resource management line. It's almost a 50% cut. The crosswalk included in the pre-hearing responses says these were reductions due to a combination of increases and decreases in NPS and NPS.
That isn't diffs related. That's fixed cost.
Fixed costs.
Yes, yes.
Okay, so 50% cut in fixed costs?
After analysis was completed from DGS and the latter part of the budget formulation process, we realized that savings, and that's what's reflected in the budget book.
So fixed costs, electricity, water,
Leasing,
leasing, okay. A lot of money that was just soon new available to you. Okay. So that that won't negatively impact any of the facilities that you currently have.
No.
Howard Road, K
No.
Street, New York Avenue, okay. All right. Okay, and just to go back, there's a $2.5 million increase for CPAP along with 10 additional FTEs. That's a move, right? Or you guys are combining two services together, or are these new FTEs?
No, there are additional, and, there are, in terms of CPAP.
Yep.
We do have an increase in, the staffing, increase of 10.8 FTEs.
Okay, I guess I'm asking, are these new FTEs that don't exist at your agency already, or are you collapsing a division that already exists into
No, these are
CPAP?
new.
Okay.
I was going to say, yes, they are funded with federal funding.
Okay,
So we're able to utilize that funding to fund those FTEs.
okay. Give me just a second. Okay, I was trying to stall. I sent a bat signal to my colleagues to let them know, hey, if you have questions, come now. I'm done with my questions I have for right now. We have some follow-ups, obviously, in terms of some spend plans, and Marcia will send that over to you guys of what we need. Is there anything I didn't ask you that you want to say for the record?
No, thank you very much for asking.
Okay. All right, so that concludes my questioning. Dr. Bazaran, I want to thank you and your team for providing testimony and information to the committee, and I want to thank you in advance for your collaboration over the next, I don't know, 50-something days as we sort of land this plane. We have some additional questions. We have some follow-ups, some spin plan questions that we have. We'll reach out. For those who are watching, if you want to submit public testimony regarding the budget for the Department of Behavioral Health, the hearing will remain open until Thursday, April 25th. You may submit written testimony via the council's hearing management system at dccouncil.gov/hearings. Our next hearing, do I adjourn? Do I recess? Okay. So I'm technically adjourning the DBH portion. We will pick up at 1:30 with DC Health right here in this room. So we'll be back in a little bit. The time is 11:25. Thank you so much.
Thank you.
No, nothing. Okay, good afternoon. We're going to continue today's budget oversight hearing. We're now turning to Dr. Diana Bennett, who's the director of DC Health, and to her team to testify on the mayor's proposed FY25 budget for DC Health. Yesterday, we had about nearly 70 public witnesses who testified in support of sustained and increased investments in maternal and infant health, healthy food access, sexual health and education, school health services, and more. I'll reference the public testimony as well as the agency's budget chapter and written responses to the committee's pre-hearing questions in today's hearing. As background, the Department of Health, provides programs and services with the ultimate goal of reducing the burden of disease and improving opportunities for health and well-being for all district residents and visitors. DC Health does this through a number of mechanisms that center around prevention, promotion of health, expanding access to health care, and increasing equity. With over 800 FTEs, DC Health is organized into 7 administrations and offices. I went through all of those yesterday, so I won't go through them today. There are a number of hearings that are going on throughout the building, so we'll likely be joined by colleagues throughout, and I'll certainly turn to them when they get there. But Dr. Bennett, we'll go straight to you. Before you begin, I need to swear you and your team in, so I'll ask that you and anyone who might speak today, if you could raise your right hand. All right. Do you swear or affirm under penalty of law that the testimony you're about to provide to the Council of the District of Columbia in this committee is the truth, the whole truth, and nothing but the truth?
I do.
Great. All right. Dr. Bennett, if you begin when you're ready.
Good afternoon, Chairperson Henderson, and to all of the council members.
Oh, you just
Staff.
need to move the mic right in front of
Closer
you.
to me.
Yep.
Is that better?
Yeah.
Okay. On behalf of Mayor Muriel Bowser, I'm pleased to be before you today to discuss DC Health's plans for fiscal year 2025 and our successes in fiscal year 2024 to date. I want to first thank the mayor for her continued investments in public health services and infrastructure. Health equity for all residents and the economic and cultural vibrancy of the district are interdependent. We need healthy communities to drive an economy and a thriving economy to support the health of residents and families. With the continued investments in the mayor's FY25 budget, we demonstrate our unwavering commitment to achieve Mayor Bowser's vision of health equity. However, this is a year in which all district agencies have needed to right-size operating costs as revenue and growth are changing. At DC Health, that has meant considering which programs and initiatives have achieved real outcomes and what new resources are required to address unmet or emerging public health needs. The decisions evident in our budget are based on those considerations. As you and the public look at the budget, I want to be sure it is with an understanding of the essential role public health plays in all our lives. Public health done well is invisible to the residents, visitors, and patients who it serves. When you are enjoying food at one of our local restaurants, walking through our streets or parks, visiting your trusted primary care provider or local pharmacy, or even jumping into a pool, you are seeing the hard work of DC Health staff to ensure those services are delivered safely. About a third of DC Health's budget goes to supporting those inspectors, educators, licensed specialists, administrators that do that work. DC Health staff also raise and administer the federal dollars that make up over 60% of our FY25 budget and fund many of our direct services. You residents know that 2/3 of our sizable budget, over $200 million out of $304 million in FY25, passes through DC Health as grants and contracts to an array of organizations and providers. Those grantees and contractors provide our community with healthy food, support for managing chronic illness, a lifeline to call when caring for a new baby, and many other essential needs. These needs must all be met within our budget, which means that prioritizing and managing our resources and investments is a key part of our mission to protect and promote the health of the district's residents and visitors. DC Health remains committed to those investments that ensure we all have a quality healthcare system, safe businesses and spaces to enjoy, and access to the resources we need to stay healthy. Access to healthy food is a priority for both our agency and for the mayor. We are pleased that the funding level for food programs remains consistent despite budgetary pressures. I'd like to thank the mayor and her team for being such strong advocates for those district residents that are food insecure. I also want to thank the mayor and council for continuing to support our high needs health career scholarship. We believe this program, which should roll out this summer, will go a long way to address some of the challenges in recruiting and retaining qualified health professionals. We're pleased to share that our new staffing model of school health services has been a success despite the mid-year challenges. As of April 1st of this year, 95% of the 182 approved health suites have 40 hours of on-site staff coverage, and the remaining have 24 hours or more. All schools have access to telephone coverage when staff is not on site. This contrasts with the staffing in past years when as many as 40% of schools had no assigned full-time on-site staff. We'll continue to work on this model in response to school and parent feedback, and we'll provide a more detailed update in advance of the new year. One hard decision we made this year was to pause our school-based health centers. The centers are small in-school clinics that deliver care similar to the services in a traditional community clinic setting, and they're done in partnership with local healthcare providers. The original purpose of the program was to ensure that students who do not have access to traditional health services or who have other significant barriers to care can still seek health services in a place they already go, their school. However, we noticed that the number of young people using the school-based health centers is well below what we would like to see in such a program. Additionally, we need to ensure that children who routinely seek care for basic needs in a school setting are not missing out on the continuity and parent involvement that are two essential elements of quality pediatric care. Therefore, we propose that for the upcoming year, these centers be put on pause while we work to better understand what healthcare needs our students have and craft an effective solution that's aligned with other elements of our school health services program and our access and quality goals for the health system as a whole. Finally, I want to move beyond the specifics to touch on the larger vision that drives our decisions. During my confirmation hearing, I talked about the vision of DC Health as an organization that was data-driven, collaborative, and inclusive, and focused on solving problems, including health disparities. I've seen a strong alignment with DC Health leadership and staff around that vision. In the nearly 9 months since I've arrived, I've also seen examples of how DC Health is already realizing that vision. Please ask me if you want to hear more about that. I'm going to skip ahead. Over the next several months, we'll be looking to continue this kind of work into the future. We'll be focused on making our agency best meet our core functions, create innovative solutions to persistent gaps and inequities, and prepare to address emerging health issues. We'll be launching some strategic conversations this summer, both internally and with our partners, to plan for that near future. One way to improve our ability to meet our core functions is reimagining DC Health structure to support more efficient, nimble, and effective public health practice. By that, I don't mean adding or removing major functions, but rather optimizing communication and partnership. We anticipate sharing more of our developing strategic plan and shifts in structure with the council in the coming months as we continue our conversations. In closing, I want to thank the council for providing DC Health with an opportunity to share our successes over the past year and our vision for the future. I'm available to answer any questions you have.
Great, thank you. I won't put myself on a clock until someone else arrives. So let's just see where we go. So let's start generally overall. The proposed FY 2025 DC Health budget includes an additional 12.7 million in operating dollars, including about 45 FTEs compared to FY 24. Is it accurate to say that the majority of this growth is due to federal funding? Okay, you guys have, somebody has to turn a mic on.
Yes, ma'am.
Great. Do you feel confident that DC Health will be able to spend down these new resources and not return any funds to the federal government? Okay. All right.
We are sure we are having a problem deciding who's going to talk.
Okay.
but
That's fine.
Thank you.
Rock, paper,
The resounding
scissors.
yes.
Somebody just has to turn on a mic. Okay. At the same time, the FY 25 budget sweeps 7 vacant FTEs, in addition to capturing some vacancy savings in FY 24. Is it possible that you all can provide the committee with a list of the specific positions that were cut and how long those positions were vacant for? Okay. Let's see. You also moved 7 permanent positions to be term positions in FY 24. What was the rationale for this particular change?
That's probably more than likely is just a correction of the position, not really moving them from one, from permanent to term. It was the correction of how the position should have initially be coded.
Okay. Across the agency, we're seeing that IT services are doubling from about 4.2 million to 8.1 million in FY 25. I mean, you guys just got a new building, so is it more money? Or why this additional funding?
So the majority of that funding is from a new grant that has a lot of IT cost components to it.
Okay, can you say more about the
We're
grant?
At the, we are participating, as many health departments are, in the data modernization push that the CDC is doing across the country. We're improving our data systems. That is what the grant is directed towards and can only be used for. And so that is where that money comes from.
Okay. All right. Okay, so the agency reported a vacancy rate of about 15.4%, which is better than previous year, which was 21%. What's your ultimate goal and steps towards decreasing your vacancies?
So we
Gotta turn your mic on, Keith.
thought it was big.
And just, I know who you are, but if you could just say your name for the record.
Keith Fletcher. Our local vacancies are about 6%. It's about 11 out of the 166 that we have. So one of the things that we do is as we get federal grants and new awards, there is a period of time that it takes to fill the positions. We typically recruit over 100 positions on any given year, about 105, 110. And our time to fill is between 45 and 55 days. So we do a reasonably good job of that. We also at the same time have attrition, to be fair. And that attrition kind of balances out what we are bringing on. So as Robert says, we are trying to onboard staff. What we recognize is that we have to do some more work in the area of retention. I think we've done better in recruitment.
Okay.
We recognize that that's a place of growth for us.
Okay. Let me ask on the recruitment stage of things, are you all satisfied with the pace of things in terms of DCHR?
The answer is yes. One of the things that we do is we recognize that there just are some positions that are hard to fill. And some of these positions are hard to fill for a number of reasons. We're competing with entities that have a different approach towards remote working.
Yeah.
We recognize also that some of the positions, some of the requirements that they have are not the equivalency of maybe what the pay could be relative to that particular position.
Okay.
So we have a few things that we're looking at. But in terms of the partnership that we have with our partners, I think it'd be fine to say that that's going as well as we.
Okay.
I would also add the nature of our funding, which comes in episodic federal dollars, means that there are always new positions being created. So the work is consistent, but the way in which it is framed or staffed is not. So the grant may have additional staff which weren't needed before because of the focus of that grant.
Right.
And then those are now open positions. They will get filled, but it's not, in most organizations, that vacancy rate would be emptying of normal positions in the ongoing work. A lot of those are created positions.
Okay. So there's a subtitle in the Budget Support Act that sweeps funding from several of DC Health's non-lapsing funds. So I want to go through them and sort of ask about some of the impact. So there was 3.8 million from the General Purpose Local Fund. What was the purpose of the General Purpose Local Fund? And what will the impact of that be?
I believe that 3.8 was in reference to the Howard Center of Excellence.
Okay, so you put the Howard Center of Excellence Fund in a non-lap or Howard Center of Excellence funding and a non-lapsing fund?
So a couple years ago, the intent was, so Howard gets funded from 2021 to 2026, and they have different tranches of money.
Yeah.
And we all had the same, we've heard that repeatedly, that we've had problems spending the money. So what we did is when we got the allocation, we created a non-lapsing fund in local so that money wouldn't go back to the general pool.
Uh-huh.
And so as we get the money for the course of the year, we put it in the non-lapsing fund, and we can then carry that money over into subsequent years.
Okay,
What
so,
they-
okay, sorry, go ahead.
Okay, so with that thought, what they did at the end of FY 2023 was that we had $3.8 million available in that non-lapsing fund. The mayor's team swept that non-lapsing fund and gave us the equivalency of that money in ARPA funding. So the net to Howard is nothing. The local non-lapsing fund was swept, but we have the money in ARPA available funding. And there's a timing piece of this. I recognize that, I think I read something yesterday that Howard got a letter saying that the ARPA money had to be spent last year by September. That was right at that time. So we were all operating under the auspices that ARPA funding would have to be spent by the end of last fiscal year.
Mhm.
We learned that they can get an extension of those ARPA funds. So we were pushing anybody that had ARPA money to spend it down as quickly as possible. We learned that it has to be spent by the end of this year, FY 2024. So what the mayor does is they swept the local funding and
Right.
gave us ARPA dollars, and those ARPA dollars are available to Howard.
Okay,
for 2024.
so on the chart that I have, the Howard Center of Excellence is in a different line item. So this one is 1010001, general purpose local fund, and then Howard Centers of Excellence is in a completely different one, 1010189.
So as far as the 3.8 in the general fund, I can look at the details and provide that.
Okay,
For that reductions. The other ones are specific for the non-lapsing.
right. That's
But
why I was like,
yeah.
what is a general purpose local fund and why is that non-lapsing?
So I can give you a list of what those reductions would be.
Okay,
Yeah.
thank you. All right, so 460,000 from the Health Professional Recruitment Fund. I know what that is. A reduction of 460,000, is that not going to have an impact on existing individuals who are in that program?
That's the high needs health career scholarships that have not started yet.
I know, but we funded it right now.
You can correct me if I'm wrong. So we did fund it, and it will perhaps a little bit.
Okay,
But we
you
are-
want to phone a friend?
I do. I'm looking at my friend over there.
Is it? So,
I want to be sure that we're saying the same thing. Go ahead.
let me see if I get my brain right. So the high need scholarship program is $1.3 million in FY 2024. We think we're going to get that program up and running in summer this year.
Okay,
So there is the potential that some of that money would be available at the end of September this year,
okay.
right?
So,
And
so it's
this-
not a sweep of the entire fund.
exactly. So
It is just a reduction.
So it's
Okay.
yeah. So when we right size by next year, it'll have no impact on what we were planning to do next year.
All right. Okay, 4.6 million from the Board of Medicine. That's sad. They use that. Was that fees?
So those are that's the fund balance that we have. The only way that could be swept is if my best friend to my right of me, Adrena, certifies that. And what she did is, what we said is, at the end of FY 2023, we anticipated having X dollars of fund balance.
Hmm.
We budgeted for FY 2024 with an estimate of what that fund balance would be. It became more than that. So what you're seeing, that cut of fund balance doesn't represent any item that was budgeted for. So there's no reduction.
So this is excess.
That's exactly what it represents.
Okay. What should that money go towards, though? In theory, this special purpose fund for the Board of Medicine, where should these fees be going? I said hypothetically, in theory.
There's anything that supports the Board of Medicine work, to include staffing, anything that the board needs in terms of travel recruitment. It supports the system that licenses all the health professionals.
Yeah.
It supports contracts that support the Board of Medicine. I
Okay.
don't know the specifics off of the
I'm
top of my
saying,
head. My
so like,
apologies.
oh, if you guys needed to do an IT system upgrade, this would have been excellent funding for that, or hire additional staff, so there's no backlog and wait applications. Uh-huh, okay. How much is left? Once the 4.6 is gone, how much is left?
That swept the fund balance.
All of it.
Yes.
Mhm. All right,
The fund balance that was not planned to be used.
Thank you.
okay.
When we did the FY25 budget, just to go, we budgeted some fund balance. So
Okay.
there was some included that was excess. That's in quotations.
I'm gonna keep this in mind when I start getting notes from some doctors talking about the long wait times it's taking for their applications.
We're working very hard on it. It is really a process issue and there's probably some policy regulation side of that. It really isn't just a pure, we don't
Right.
have enough bodies to do it. We're gonna work.
To be honest, I think that like these types of funds, where you're taking fees for something to better improve the process for the whole is important. We have the same conversation over with DDOT, right?
Mhm.
In terms of automated traffic enforcement, we tied the automated traffic enforcement revenue received to safety improvements and traffic infrastructure, so people can sort of see the one-to-one. When these get continuously swept into the general fund, it causes a little bit of frustration for folks, overall.
I think it's important to know too, that over 96% of our health professionals renew within 3 or 4 days with no problems.
Oh, I know. I've heard
so as
the
we are-
talking points from the performance oversight.
It's important that the that's also known.
Okay. One more fund, 1.2 million from the SPRF for SHPTA fees. My understanding is that this fund is supposed to be used to pay salaries and programs at SHPTA. Is this extra?
It meets that same criterion. It's just unplanned use of the fund balance.
Okay, so how has this money ever been used for salaries and programs at SHPTA?
It is used for salaries.
It is
In
used for-
addition to other non-salary related expenditures.
Okay, so the 1.2 is excess.
Yes. Unplanned or unbudgeted for.
Okay, unplanned or unbudgeted for. Okay. Now, in terms of the subtitle, and correct me if I'm wrong, even though it sweeps the funds, it doesn't get rid of the funds. These funds will still
That's correct.
exist.
That's correct.
All right. Okay, all right. Let's talk about some of your agencies. We will start with agencies, some of your administrations. We will start with HEPRA and CPPE. Okay, at the performance oversight hearing, we discussed several reporting delays for HEPRA reports and data analysis because there's a small number of data analysts on that team. Does the FY25 proposed budget provide adequate staffing to meet HEPRA's current reporting deadlines?
I believe it does. There's some backlog that we're gonna work on, and I'm gonna let you talk about that. Go ahead, introduce yourself, Sam.
My name is Sam Hurley, Senior Deputy Director for the Health Emergency Preparedness and Response Administration. To continue as to what Dr. Bennett was alluding to is that as we iterated in the oversight hearing, there were some delays and some backlog in analyzing reports and actually receiving some data in particular, the trauma registry. However, we have fixed those issues for 3 of the 4 hospitals. And we are working with the last hospital to finalize all of the details with that fix. Part of the problem is that they have implemented the next data standard, so they got ahead of us. And so there's very little backwards compatibility. So we're having to go in and manually amend the data to make it work. But as I promised in the compliance hearing, I will be providing the answers to those trauma registry questions to you as soon as we have that data manually fixed, but I want to
Okay.
answer your questions.
How many people do you have working on the trauma registry project?
Currently, I have one epidemiologist within my administration working on that project. However, we are partnering with our federal colleagues to bring on a career field epidemiologist that will be assisting with projects like the trauma registry.
Okay. Dr. Bennett, in your testimony, you mentioned that HEPRA's new data analytics tool is being used to for FIMS data or used with FIMS data, or taking FIMS data for the tool, including traffic injuries and near fatal opioid overdoses in real time. Are there plans to make any of this data available to the public?
So the tool that we implemented is called Biospatial. It's a tool that's made available to states. And it currently does not have the capacity to make the tool real-time available for the public use.
Okay.
We are working with that organization to determine, is there a use case to make some of that data available to the public?
Mhm.
That said, we have been in conversations about pulling down specific reports and making those items available to the public.
Okay. Do you have the resources to be able to align this data with MPD?
That is something that we are working collaboratively with the DDOT, with the Department of Transportation.
Okay.
Through some of their highway safety grant funding to help build out a plan for integrating MPD data to complete the spectrum from interaction with law enforcement, interaction with EMS, and then interaction with our trauma system.
Okay. DC Health requested approximately 400,000 at a recent opioid abatement advisory committee meeting to improve data collection and analysis on opioid related overdose. Is this funding included in the FY25 proposed budget, or have you come to an agreement with DBH about the transfer of those funds?
It's this year's 400. That was this year. So we were able, that was part of the MOU. You can go ahead and describe the rest of the MOU.
So that's a FY24 item?
Yes.
Okay.
And
Have
that
they
is-
transferred the money?
Have they?
I think they've given us access to them.
Yes.
I can hear you.
It's
They
a
can
lot.
hear you. Yeah. They've given you access to the money.
Yeah, so that included the coding changes to make the biospatial optimal. And it included the vending machines that we talked about and a few other things.
Okay. Did that require reprogramming or just okay, cool. Okay. All right. The State Health Statistics Division will gain 11.6 million, including 10.6 new FTEs in FY25. Are these federally funded? Okay. Federal. Now, are these new? Are these? So somebody got to turn a mic on.
They're both CDC programs, and really, one is our standard funding vehicle from the CDC for all of our investigative work and all of the reporting that we do. And that fund and the data modernization have both been used to encourage health departments to work on their analytics and data reporting,
Okay.
which is what we're doing with it.
Now, it says, or it appears as though it's like 10 new FTEs. Are these truly new people, or are there folks that you already have that are now going to be sort of moving into these positions?
I don't know that answer.
Yeah, I believe some of them are transferring from what we often do is people are transferring from one grant onto another,
Okay.
and they are continuous people, but they are funded by different things over time. I can't say specifically for those positions. We'd have to look that up.
Okay. Yesterday, Is this the vital records? Vital records. Oh, okay. Okay, so yesterday we heard from several witnesses about negative experiences with vital records. So one witness testified about her client's experience trying to use the language access line while at vital records and being quote unquote assessed as to not needing it, saying her English is good enough, even though she didn't understand. And when the resident asked for interpretation, or basically, the call ended in that, or I guess the call continued, although the resident couldn't understand. What's the policy in terms of when a resident asks for interpretation? Shouldn't you all automatically offer it as opposed to doing an
Yes.
assessment of whether or not somebody?
Anyone who says they can't understand should be given access to it. We have language access staff who that is their role to encourage that and to make sure that system's functional. Any kind of individual customer service issue is certainly important and we will look into. I don't think that that's an overall policy.
Okay.
That needs a policy solution. I think we need a customer service solution, which we will. work
Okay. And it could be just around training of when you're onboarding someone to say, here are the language access opportunities that folks have. And when they request it, this is what you should do. It's a simple training piece. Now, the other complaint is perhaps a bit more complicated. So a witness testified about she had a home birth,
Yep.
felt that the process is very opaque and complex and inconsistent. Is there any way that DC Health can just post some uniform guidance about home births on your website? So it's sort of a,
Yes.
so you want to have a home birth?
Yep.
Maybe have a witness who's not your partner.
We're going to have some information. First, I will say that particular case, there are many things that would not have helped in that case. So we will do some posting to make sure that there is a place people can go look. What is it I have to do beforehand? It is incredibly rare. So 0.5% of all births in the district are unattended.
Mhm.
No, it's 0.4%. And many of those are accidental births in cars or grocery stores or wherever. They're not intentional. So a birth that is unattended on purpose, that does not involve EMS, that didn't involve a doctor or nurse of any kind within the first 2 weeks is an incredibly rare event that I don't think we're going to do any kind of bureaucratic fix for, but we are going to inform people so that they prepare better. I think it's not going to be, it will not be needed by most people.
Right.
Because they are using a midwife or someone else who's quite adept at this process and does know the procedure.
Yeah.
And their signature is sufficient. It's only when you don't have it, they do have all these other things.
Right. I just think sort of in general, as we see a number of whether or not it's whether or not it's intentional or planned, as we're seeing a number of women who are choosing to have home births, it's just a part of the process in terms of
Right.
what folks should know. In terms of our requirements, and I'm not suggesting that we don't have requirements. Obviously, we need to, yes, prove that the child was born on the day for which you claim it is, and that
It is yours.
it is yours. That
Yes.
part key. But have you all done sort of an audit of comparison in terms of what we require as proof of documentation versus surrounding jurisdictions to ensure that we're not some outlier in terms of our requests?
I don't think we're an outlier. They're not exactly the same, but
Okay.
that there are slightly more options. They are probably not relevant in almost hardly any cases.
Okay.
So I don't think it's a major difference, but I am comfortable with the security that we are giving people, that we are only giving a birth certificate, which is a single source of truth, to people who we know that the child did not come from somewhere else.
Yeah.
And does not belong to someone else, did not get born somewhere else. So a birth certificate is a very powerful document. That
Yes.
pretty much trumps all other things when you're trying to dispute something. So we are very concerned about the security of the system, and that is why the requirements are there.
Okay. Let's talk HOSTA. The proposed budget includes a cut of about 4.2 million of funding from HOSTA, which I believe is mostly a federal grant
is.
funding. I don't know. Okay. Um, in sort of your conversations with our federal partners, do you know specifically why they are decreasing funding for this program?
I'll let you respond.
If you can introduce yourself for the record.
Good afternoon. I'm Clover Barnes. I'm the Senior Deputy Director of HOSTA. And basically, we are being cut because we've done a great job. We've reduced our prevalence of HIV in the district by 11%, and thus we are receiving an 8% cut.
This is actually a very common CDC process of, it's based on need. You did great, you don't need as much anymore.
Okay.
That is not always reality.
But we
because-
didn't completely eradicate it.
Right?
And
And it's low because we put in lots of effort, which we need to continue. So we will have to do some work to see what's essential, what's effective, and Clover's gonna have some work to do
Okay.
on which things need to be adjusted.
okay, because I'm trying to sort of take that in a cut, or what the public might see as a cut. And then also you just put out a report that says, we're seeing some increases in certain particular subgroups. And so do you feel like with the funding we have available, we'll be able to appropriately target those subgroups that are seeing increases?
I feel like we're going to have to make some hard choices around what we can and can't do.
Okay,
The required things we're going to have to do, and some of the other things we won't be able to do going
all
forward.
right. How many FTEs was adjusted or impacted by the loss of this grant? Or sorry, not loss, reduction in this grant?
So far, 5.
5. Okay,
That's still a fluid process, though.
Yeah.
Okay.
So we don't know all the numbers yet, so it doesn't line up exactly with our budget season.
mhm,
So there may be more news. But
okay,
we cannot do everything with less money. So I don't want to give the impression that we're saying that we will do the same amount or more with fewer resources. We cannot do that.
right. I mean, as Director Barnes said, you're gonna have to make some tough choices. I'm just curious to what extent. I would love to know how this is gonna impact, whether it be data collection or research or outreach or programs. Have you all sort of made those determinations of where you're gonna have to,
So the grant funds HIV prevention and surveillance. And
Oh.
so it is the very things that we need to continue to do.
okay,
It's not an open choice.
all right. Now, as we're sort of speaking about HIV, like I said, I think that the percentage of district residents living with HIV who are in treatment, the percentage of residents living with HIV who have reached viral suppression, and the number of new diagnoses, it seems to have sort of stalled in all the areas. And by that, I mean, we have these very ambitious goals for 2030. How are we going to get there? Can we get there by 2030?
So it's possible. We have plateaued. And I think what that means from my perspective is that the things that we have done have worked, and now we need to reach people who haven't been reached by the things that we have done.
Okay, so
It's going to
thinking
make it
outside of the
harder.
box.
Exactly, but it's going to make it harder because the things that have worked, some of those are going to have to stop. And so it's going to be a delicate balance to decide what we do and what we don't and how we try to reach those people. There are some people who are just averse to coming into the system. And so what we've been talking a lot about is doing things that bring services to them as opposed to trying to make them come to us. And so we'll have to figure out how we can do that with the funding that we have.
This
Okay.
is going to be a very challenging area because as you go to those people who are hard to reach, it takes more effort and more resources to reach each of them than it does to reach each of the much easier people. So it's going to be a balance and won't be one-to-one.
Okay. All right. DC Health's 2022 HIV STI data shows an increase in syphilis cases amongst women and their babies in 2022. Does any initial data that you guys have in-house from 2023 indicate that that was just a spike and not a trend?
So it was a trend that it increased over several years.
Okay,
And 2022 was like the crescendo, it was the peak. And
okay,
then in 2023 has gone back down.
all right.
So we noticed the trend going up and implemented different things along the way to try to work through. There's a big push around it now, so it's getting a lot more public knowledge.
Okay,
But we started that before the public knowledge came, and the numbers are on their way the other way.
okay. We heard from several high school students yesterday about the need for increased investment in peer-based sexual health education in schools. Do you agree that this would be an effective strategy for helping to prevent STIs and increasing sexual health education?
I definitely think it would increase sexual health education for sure.
Okay.
I do actually think peer-based services can have a great impact. It depends on how they're run. But when the right youth really do know what they're talking about, they can have an impact on what the others do. So it is, I think, something we should.
Okay. Does the
Just
FY 25
pursue.
budget include funding for your? It does not. When's the last time that we had it?
I'm gonna guesstimate it was maybe 2018 or 2019.
Oh, wow. Okay. So pre-pandemic was the last time we did it. Were you here, Director Bond?
I was in a different role.
A
I
different
wasn't in
role.
this
Okay.
one.
So I was gonna ask, how much did it cost? But I don't know. Everything is more expensive than it did in 2018. All right. Okay. And just for our clarification purposes, is it accurate that DC Health, the budget does not restore the grant for Joseph's House, which provides low-income individuals with chronic disease with care and support?
That's correct. The one-time funding in FY 24 was not restored.
Okay, was all one-time funding just cut?
No, that would be no.
Okay, so do we not see value in the work that Joseph's House is doing? I mean, I've gone to visit and just in terms of their outcomes, you know, you have folks who are going there in terms of hospice care, and yet they are still alive and very much able to move out on their own, which shows that these types of interventions can certainly save lives.
The only funding we have that could fund that is Ryan White funding, and they weren't eligible for Ryan White funding.
Okay. I think I knew that. Or I have to sort of dig back in the files of my mind, but I think I knew that they weren't eligible for Ryan White. Okay. Okay, let's move to HRLA. Just so large. Okay, so the proposed FY 25 budget reduces the contracts budget for the Office of Food, Drug, Radiation, and Community Hygiene by about $750,000. What contracts will be impacted by this reduction? You just introduce yourself for the record.
Arian Gibson, Senior Deputy Director for Health Regulation and Licensing Administration. So we have several contracts that we have. Some of them are with laboratory partners, others are with special witnesses or special what's it called? When we go to court, the special consultants, things like that when we go to court.
When we go to court.
When we go to OH and we have to testify, we need
Oh, the expert witnesses.
Yes.
Okay,
Yes.
so losing that money, does that mean we're about to lose more cases?
No. That's not the intention. So we're not gonna have no expert witnesses. We just have to, yes, and we have a smaller amount and we have to
Adjust.
make some decisions, yes.
Okay, so that 750,000 is mainly for that purpose, or were there other contracts that were reduced?
I would have to get back to you for the rest of them.
Okay. This office also will receive 6 new FTEs. Are these local or federal positions?
Those would be special purpose revenue funded positions. So neither local nor federal,
Okay.
primarily Board of Medicine.
For the Office of Food, Drug and Radiation and Community Hygiene?
No, it's not radiation.
Okay, what's the purpose of the 6 FTEs then, is my question.
So I do know that the sanitarians were put back in there.
To be
Make-
federally funded now?
No. So, no, the sanitarians are not federally funded.
That's what I know.
We don't have many federally funded positions in that office.
Okay, so let me restate my question. So we're talking about the Office of Food, Drug, Radiation and Community Hygiene. We are showing that you're getting 6 new FTEs in this office. We're trying to figure out, number one, how are you funding them? I think she said they're special purpose revenue funded. Cool. Number two, what are these people going to do? Okay. All right. Add that to our follow-up lists. So in your testimony, Dr. Bennett, you reference food safety as a core public health function. Yet in the pre-hearing responses, DC Health reports that with a flat number of food sanitarians and an increasing number of food establishments, DC Health foresees fewer establishments will receive the required inspections for FY 2025. Oh, you got to turn your mic on. Because
For this year, with the tightening that we're seeing, we were going to have flat funding for many things. In this case, I do think there's some changes that might be helpful in the way in which we schedule them, in how we deal with complaints, and the amount of inspection that goes into that, and the way it changes the schedule. So there are some efficiencies that might lessen the impact of that, but we do have to do as much as we can with less.
okay. In the same vein that you guys have a special purpose fund for Board of Medicine, and say, you know, ABCA uses the fines and fees to be able to fund its inspectors, et cetera, why is there not a similar structure for DC Health in terms of using fines and fees from inspections to fund your actual inspectors? Or to keep pace, something. I mean, I got new restaurants opening up every day. And I know for the new ones, you certainly get to those,
Yes.
but it's getting increasingly, at least for me, I feel like I have too much information now when I go out to restaurants to be like, I don't know. Did you get an inspection this year? I can't say.
Yes, so I'll let Mr. Fletcher go. Go ahead. So, okay, I'll go. So,
Turn your mic on.
No, feel like I'm constitutional. The a couple years ago, we had a local O-type fund that we used to use to do that. It was
Okay.
about $1.2 million, and that fund was swept, and we got local appropriated dollars in that. That's one component why the O-type fund actually went away. We
Okay.
operated
So
like
you
that.
tried this and it got
We
swept.
worked like this for quite a few years, at least X amount, 10, 12 years. And then the other part is we also have this arrangement with DCRA. Oh, sorry. The acronym, can you?
DCLP.
DCLP. And they collect the licensing fees associated with these facilities. And they should be,
They don't share.
thank you.
It's not entirely clear that everybody's aware of what should go where. So we're in conversation about where the permit part of the fee goes.
All right. Part of me just wants to introduce like a Bloomberg type bill that would require you guys to give scores to restaurants just to see whether or not we could do it. But I know that we can't. We literally don't have enough people to inspect the restaurants and facilities that we have on the required schedule that we currently have. Unless I'm
Well,
dealing
the
with
schedule is
sushi.
maybe not as straightforward as it seems. There is the schedule, and I'm gonna let you expand on this, but there's also the way we do the process is going out whenever there's a complaint or somebody calls. Those probably don't all need to be addressed in that way. Some of those maybe would alter our regular schedule and they don't really. So there are some ways in which we can probably adjust that to do better. But we don't control the number of restaurants that open. So we just sort of.
And I'm not suggesting that we
know.
have fewer at all. In fact, I think, one of my colleagues is having a hearing on one of these floors, millions of dollars that we're putting towards economic development to get more people to open up restaurants and food establishments and get people to come back downtown. Yeah. But on the flip side, it's cringy when you go on social media and see some of these videos. I don't want the public to have to be our inspectors.
So Councilmember Henderson, you're absolutely correct. We don't have enough inspectors for the amount of restaurants that we have. That's absolutely correct. That's why we follow the risk factor model, because this is a common phenomenon across the nation with all health departments. Several years ago, we had an audit done. It was us, New York, all like cities, New York, Miami, things like that, and all of us are understaffed for the amount of restaurants we do. So that's why we do a risk factor. As Dr. Bennett discussed, we are looking at reimagining how we do our complaints. So for example, we go out within 48 hours of every complaint. It could be, I got a hair in my food. Yes, that's disgusting, but that's not going to make anybody sick. Yes. So do we really need to go out within 48 hours for a hair in your food? So that's the type of thing that we are opining on.
Can
Okay.
we be modified about some of what we do in some places? So we just need to regularize the model so
Yep.
that it actually lets the job fit the staff. And we need to have some real conversations about where the funding is coming from and where it went and
Yep.
things moved around and people just kept going. So we're going to step back and take a look.
Okay. So there are a couple of things that I hope that we can, that I can't resolve in this budget, but I'm going to say outline of what we hope we can do. So number one, of you guys retooling the complaint process. The second is having a real conversation with DLCP about the fees piece around who gets what in order of those pieces. And the third, in terms of the recruitment, maybe not for the sanitarian positions, but if there are other smaller positions, is that you guys have a conversation with OSSI about the advanced technical center that they are opening next year that are focused on health related fields, because this might be an opportunity to get some little young minded individual interested in doing this, as opposed to being an inspector for APCA, right? Like there are various pathways here. And so let's try to work on those three things over the next few months. Those are three things that aren't going to be resolved before we vote on this budget. But I feel like to get this right, we're going to have to invest some time there.
We're going to have that conversation with our education partners tomorrow.
Okay, great.
Councilman Henderson?
Yes.
One correction.
Okay.
The 6 FTEs, 4 of the FTEs were actually local positions, and I can get details on what the actual positions were.
Okay.
And then there were 2 that were funded out of the Pharmacy Protection Special Purpose Revenue Fund, not the Board of Medicine.
Okay. Okay. I'm still interested in what the 4 local people do. So you guys can provide that in
Sure.
follow-up. Okay. Health licensing. Now this is just a discrepancy. I hope we can clear up very quickly. So your budget chapter is showing that you have some 4.8 new FTEs in the Office of Health Professional Licensing Boards. But in your pre-hearing responses, DC Health states that this office is not gaining any FTEs. Now, what I have been told from the council's budget director is what we see on the books is actually what's in the CFO system. So if we need to make an adjustment, let us know.
So I'll start. The budget book would be accurate and it would be based off of what is in the financial system for formulation. So there's no error. It could just be a correction of how a position was previously coded from the prior budget. So that variance is an accurate variance from FY '24.
The variance is accurate. Are we getting new people?
And so in the response, as it relates to licensing, yes, we are getting two new FTEs for the Office of Health Professional Licensing Boards, but they are going to be focused in the compliance realm. So that was the complaint coordinator. And then the other realm was an investigator. And then the third position was the high needs scholarship program coordinator. So those are the three FTEs that was awarded that is in the FY '25 budget for the Office of Health Professional Licensing Boards.
Okay. Now, the budget chapter shows that the Office of Health Facilities is losing 5.1 FTEs. Is that accurate?
Again, the number would be accurate based off of FY '24 formulation. The specifics around the positions we can provide.
Hi, Renata Cooper. I think the correction would be that the positions that are listed, they are partially funded because the Office of Health Facilities, through the Social Security grant with CMS, some of the positions are locally funded and the rest of it is federally funded. And so we moved some of the positions based on program needs where staff, like when individuals retired based on where the needs were for all of the office health facilities. For example, if I have more nurses in one program, however, I'm growing more in another program, we repurpose the positions and move them over to another space. But we can give you the specifics around which ones those were.
Okay, but is there a net loss of 5?
To my knowledge, we're not losing 5 positions. They may be showing up as a loss based on how they were, where they're going, but not lost.
So again, it could be a correction where there's an offset and another activity within the Hurley administration. So overall, I would say there will be no loss, but it is showing a loss in that particular activity.
Okay. All right. Let's talk animal control and care. The FY '25 budget proposal includes $22.5 million in capital funds for a new animal shelter at 4 DC Village Lane Southwest to replace the New York Avenue shelter. All of this capital money is in FY '25. But in the pre-hearing responses, you all indicate that the executive is still considering a more publicly accessible location. So is the location not final?
I believe there was a brief pause to consider. I have not heard the results of that. It was a late arriving proposal. And I have not heard the results, so I don't think they've completed that decision. But it sort of came midstream.
Okay.
Otherwise, we would be starting with the new fiscal year.
Okay. Even with these sort of we're seeing, we're not seeing, et cetera, are you all confident that can begin the build, whatever sort of rehab or reconfiguration needs to happen for that new facility started in FY '25 and finish it in FY '25?
I think the timeline is 18 months.
Okay, so start it in FY '25.
Yes,
Finish it in '26.
yes.
Okay. All right. So right now, I don't see any set aside for maintenance for the existing shelter at New York Avenue.
For those, that will come in the FY. The operating cost of capital will come in once the product is, once the facility is delivered. So 20.
No,
No, she
not
means the
not for
existing New York
not for
Avenue.
DC Village. I'm talking about the existing New York Avenue shelter. If we are going to be keeping this shelter open until 2026.
So we have operational costs that are in our fixed costs through and managed through DGS. So it's included in our estimate from DGS, that particular location.
Okay. So is there sufficient funding to maintain that building over the next fiscal year? New York
Yes.
Avenue. Okay. Barring any hurricanes, tornadoes, strong winds, et cetera. Okay. In your testimony, you described DC Health's conversations with the Humane Rescue Alliance to improve animal control services. The funding for the animal control contract remains flat, 4.7 million. Does DC Health foresee any changes or improvements to the contract in the next contract cycle starting October 1 that might change the funding level?
We
Just
are,
leave them on, and if
Yeah,
we get
no.
feedback, then we'll
Okay.
get feedback.
there will be some change.
Okay.
We are in that conversation right now, so I don't know what the change will be. I don't want to declare something that will be untrue in 2 weeks. But we are talking about the things that we discussed before, regularizing the contract, so it's a little clearer what is being paid for and who's doing which parts. That will not necessarily make anything cheaper. So we will have to look at how we approach the possibility of a shortfall and going forward. I know that's happened repeatedly in the past, but at the moment, there doesn't seem to be a place to take additional funding from. It probably will have some additional cost, no matter what we do. It's very hard to tell before we get the new building, what kinds of changes we can even really make at this point. So we may end up doing exactly the same as we're doing currently until that happens, but we are in discussion.
Okay. And if you could, and I don't know, you could say if you can't say or not, but it would really help my inbox in terms of the number of emails that I'm receiving.
Mhm.
We don't foresee changing our contract vendor before
No.
October 1.
No,
So they're here.
yes,
So we're gonna just have to make it work.
yes. It would be quite a, I think that the process of moving that entire service will be something that could be considered when we have a building. In the meantime, it just isn't logistically feasible at this point and should not be done in a, short few month kind of consideration. It really is going to take some real time, and we're going to have that time to talk over the next year.
Okay. All right, public, you've heard. HRA is here. We're gonna have to make it work. And we're in conversations to make the
Mhm.
relationship better.
And we'll be able to tell better what their performance is when we have a much more clear contract around what the expectations are. The current contract's somewhat vague and doesn't really give us the structure we need to do oversight in a way that would help the public be assured.
All right, so we heard from some advocates for street vendors yesterday about their frustration that the emergency regulations, which were due on November 15th, 2023, have yet to be published. What is the timeline for finalizing these regulations?
Yes. So the regulations are in a review process, and once the regulations are fully approved, we're prepared to stand up our program. We have completed our online application. We have it in different languages, so we're just waiting for them to be approved.
Okay, you didn't answer my question. I said, what's the timeline?
We are not the approvers,
Yes.
so we.
Okay,
can't-
who are the? approved-
the process goes through all of the mayor's office, the CA, we are the creators, and then we give it, and then we need to have it reviewed.
Okay, whose
legal-
office? Who has it now?
Sure.
Oprah.
Okay. All right, it's helpful to know. The witnesses testified that DC Health had issued cease and desist orders and threatened $1,000 fines for vendors in Columbia Heights. Even though these vendors cannot get their licenses without regulations being finalized. Would you all like to respond to this concern? or
Do
accusation?
you want to respond with what happened and I'll respond with what we think about it?
Yes. So we received a complaint about vendors operating with potentially hazardous food and open flames. So we went and we did find, I think it was five vendors who were doing that. So we did issue a cease and desist. We did not issue any fines. To that point, I think they called the office and talked to a staff assistant and they asked, what is the penalty for operating without a license? And our staff assistant told them it's $1,000 fines for each day you operate without a license.
Right.
I also would like to add, there are other avenues of becoming, so we have the college food program, we have the vending program, but the avenue that they're choosing to go to is the micro enterprise avenue.
I just want to clarify though, they were cited for health code issues. So there is never a time in which you can sell meat outside of temperature control. There will never be a time in which having an open flame on a street will be okay. So if we fast forward a year and the licensing process is functioning well, they would still get cited. So I want people to understand that there isn't a place in which we're going to be okay with things being unsafe for the public. So there won't be any relaxation in that realm. And we do want people to be able to have their businesses legally. Part of that is educating them about how to do the food preparation in a way that prevents 20 people from getting food poisoning on that street. But that is going to take some time, even after the licensing process. But what was happening was not legal and will never be legal.
Okay. One of the things, as you guys are kind of going through this process, particularly as we're dealing, with this population of business owner vendors, is that, at least my understanding, the cease and desist order was only in English. And these vendors do not speak English. So how do we plan to address this in the future, in that, at least my understanding is that they were handed the piece of paper and they just continued to do what they were doing, partly because they didn't understand what the piece of paper said.
So if that's the case, then we will rectify that. We do have bilingual inspectors. I think we have inspectors that speak 6 different languages, including Spanish, which is predominantly in that area. So we would definitely take that back and correct that.
Okay, great. All right, so I think the city administrator's hearing is coming up. So I'll inquire there about when are we going to get these regulations that were supposed to be done in November. Okay, great. Let's go to CHA, Community Health Administration.
Oh, Mr. Cheeseman.
So I was happy to see that DC Health maintained the council's FY24 funding levels for the Healthy Food Access Grants, including Joyful Food Markets, Produce Plus, Healthy Corners, and the home delivered meals. This is especially important since the other agency that has some food access related grants, DEMPED, they lost all 30 million of their ARPA funding for food access. Now, the funding in the grants spreadsheet appears to be recurring. Can you confirm if that's accurate or not? Or are these still one-time enhanced? Or
It's still one-time funding.
it's still one-time? Darn. I was hoping for better news. Okay. We heard from advocates yesterday that 5,000 individuals submitted applications for Produce Plus in the first 24 hours. Which is up from 3,000 individuals a year ago. Last year, this program had about a 4,000 person wait list. I think Hugo said yesterday they have 8,500 folks on their wait list now. Does this level of demand concern you as the funding for this program remains flat?
This is a very tough budget year. I was actually quite happy that we did not lose any funding in key programs like this, but the need is bigger than the resource around food security. I think that's been true for some time.
Yeah. They mentioned yesterday, or Hugo mentioned from Fresh Farm mentioned yesterday that $600,000 increase would help decrease the waiting list. Do you guys agree with that number?
Yes, I'm sorry, Brian Cheeseman, I'm the Deputy Director for Operations for the Community Health Administration. And yes, we do agree with that number.
Okay. All right. So last year, DC Health proposed spending $550,000 in one-time funding for dental services for seniors, testifying that the need for this program was far larger than the resources allocated. I wanted to trim this program, and you guys said, no, we need this money. And then we got FY25 budget, and the program is no longer funded. So what happened? Is it just another chalk up to a tough budget year that
Yes.
we weren't able to continue that funding?
Yes.
Okay. How many seniors to date have been served by this?
Do you know that number? I will have to look it up for you.
Okay. We will follow up on that. And I just want for the public, the 550,000 is not the only dental services
No.
grants that we have. We have a partnership with Howard University, which also has a senior dental clinic. I think we paid for that senior dental clinic. I did ask them, I was like, do we get a donor's brick as DC government because of the amount of money that went to the dental school? Okay. Dementia training. We've been trying to do dementia training since 2019. You know, you guys have money in the FY24 budget right now. Are we doing it? Are we not doing it? What's the reluctance to do it?
Right now, the procurement for those services are with the Office of Contract and Procurement. We do expect that award to be made relatively soon.
Okay. So it's a contract. So can you just say a little bit about what's the vision for the type of training, or how the training will be deployed? Is it a virtual? Is it an in-person? Is it a training module?
A minute.
Okay. It's on.
Oh, sorry. Okay. It's virtual. So the contract is to hire a company to develop an online training that the providers can use at their leisure to train their staff. Also like a train the trainer. We felt like this would be the most cost-effective way for the providers to implement this program requirement, so that we understand that they will have to train essentially all of their staff on an ongoing basis. So to have something that is not that we have to bring everybody into a classroom all at one time and doing these training days, they can do it at their leisure by logging in. They have the trainer for their specific facilities or through the association to be able to train their staff as they hire.
Okay. So for the 170,000 that we have for FY24, will this allow for the training to continue in FY25, considering they're just now getting started, or will be getting started soon? I mean, it was one-time funding. I'm just trying to understand, like, we're spending one-time money to do this, but then we're not going to get a full fiscal year out of it. So like,
It's my understanding is that what we've requested is for the development of it for us to then have long-term. If we were to
Okay.
develop something later on, as we see changes in the community or changes in the illness where we feel like we need to enhance that,
okay.
that is something I think that we would explore in partnership with CHA at that time.
Okay.
through our-
So
Benefit of virtual training. It's a high upfront cost and a low maintenance cost.
love it. All right. So I could tell the American Alzheimer's Association
Mhm.
that the training will continue in FY25. The funding was just for the build out of the training.
Correct. It'll be an educational requirement for those provider types long-term.
Okay.
The regulations have been drafted. We're just waiting on to finalize this piece.
Okay, great. All right, let's talk Howard Centers of Excellence. So I had an interesting back and forth with Dr. Mighty yesterday. And sort of us basically trying to understand what's going on here. So the proposed FY25 budget zeroes out the non-lapsing fund for Howard Centers of Excellence and allocates no additional funding for the COE in FY25. Dr. Mighty from Howard testified that they are not sitting on a fund balance of 15 million
No.
in unspent funds because those funds were zeroed out as well. So am I to understand that we are stopping to fund this Howard Center? We are stopping our investment altogether.
Mhm.
There's no money in the FY 2025 budget for the Howard Centers of Excellence.
Okay.
It was always going to stop, right? It wasn't.
No,
a
I know,
perpetual
but it was 5 years, right?
Yes, it's stopping a year early.
It's stopping a year early. Okay. Okay, we talked about this at the performance oversight hearing, right? Some of the parts of that work has been operating better than others. The work that they do on sickle cell, the work that they do on violence prevention centers, the work that they do on dentistry, has perhaps been I would say they're top performing in terms of impact and work. Has Howard indicated to you that they can continue the work that they are doing without our investment?
I have not heard this.
No, they have not. The information about the FY25 funds being zeroed out was just made aware to Howard, so they have not had a chance to respond as to how they would operate going forward.
Okay. So you guys haven't, okay. So I was gonna ask to what extent they say if we had at least X, we can continue existing programs. Because they're doing what? Hospital-based violence interruption programs and a couple of other things that are kind of crucial in our overall public health goals and the work that we're doing. But you guys haven't gotten that far yet with them. Okay, so let's follow up, circle back on those.
It's been a compressed budget discussion.
What's that?
We've had a compressed budget.
A
discussion, so.
compressed budget. Yes. Okay. The FY23 or FY25 budget maintains the 1.3 million for the high need health career scholarship and the health professional loan repayment program. You mentioned in your testimony that these should roll out this summer. What does that mean? Is the application going to go live, or are people going to start receiving the scholarships for next academic year?
Both of those are true. The application will go live and people will then get their scholarships for next year.
Okay. Okay. Will any of the funding for FY24 be spent before September 30?
Yes, the application related stuff. Is there anything additional beyond the application related?
You want me?
Just give her a receipt.
You have a cohort, right?
So our goal is that we will be awarding scholarships to programs this summer. So most of the NAP, the nurse assistive personnel programs, are cohorts that are 6 to 8 weeks. So we anticipate being able to award scholarships to those programs. Also award scholarships to some of our EMT cohort programs. We missed out on the ability to do the paramedics because their programs are usually 9 months. So that our goal is that we will be issuing those in FY25.
Okay. All right. A witness testified yesterday advocating for an increase on the tobacco and e-cigarette tax, in part to pay for smoking cessation and education and prevention programs. Does DC Health have a position on increasing the tobacco tax?
Not particularly. I think we need a longer conversation about what we'll use it for.
Okay,
We do have tobacco control funds that we are using in programming, so I'd really need to look at whether we thought there was something that we would want to pour more money into. We have lots of needs.
all right. Okay, school nurses and the health centers. So we talked about the school-based health centers at performance oversight, and we noted, or at least I noted, that, you know, some locations have higher utilization than others, and that could have to be new contract, the outreach that that particular contractor is doing specifically with the students, et cetera. So at least you said that we're putting a pause, but what we see and sort of reflected in the funding is that there's still $600,000 that's left. Is this intentional to keep a center or two operating, or are all of them stopping?
No, that's correct. Your initial statement is correct. It's 7 centers. They funded at about 300,000 each. So the 600,000 that remains, we're assessing whether we're gonna be more focused on 1 or 2, the better performing ones, and deciding, we're still determining how we'll allocate that remaining balance.
For what, on telehealth, there are multiple things we could do in replacement. And that may be just 1 or 2 centers, or it may be something that is a replacement across the board. It's a late arriving piece of news, so we're still working on the program.
Okay. So in that, I mean, for the school sites for whom you decide perhaps to retool or not continue, do we account for that in our nurse count? Because these are comprehensive high schools. So if they don't have a school-based health center, they're gonna need a nurse or a health tech. No? These are new
They have
sites.
both.
Do they have both? I don't think.
They all have both.
Oh, they have both?
Yeah, they have different functions. So yes, they have both.
Okay.
The school-based health centers were not giving out people's medications or dealing with minor injury. I mean, a little bit, but that is not their function. So that's not what they were doing.
Okay. When will you all communicate with the 7 high schools of what the plan is for next school year, for school year 24-25?
Give us a couple of weeks to talk through what we want to do, and then we'll talk to them. So
Okay.
before the end of the school year.
Okay. I will just say as a plug, I think the school that has had the highest utilization, their particular student makeup, because they do have the international, what do they call it? The International Academy of International Students, new arrival students, part of it. That might be a good candidate to continue it, because those students are truly not connected with other health homes in the community for the most part. Okay.
Councilmember Henderson?
Yes.
I think this may be a good point, since we're on the school-based health centers. That 1.5 was actually a part of the 3.8 reduction that you had mentioned earlier from the local operating. And in addition to the 1.5, it was a 1.4 reduction in fixed cost from FY24. And then, of course, the 7 FTE reductions that you had mentioned as well was roughly about 800. And then there was some smaller other type of reductions, like in supplies and things like that.
Okay. Okay. All right. So we'll circle back on this school-based health centers to kind of see where we go from there. So yesterday, Dr. Nathaniel Beers from Children's School Services, or Children's National, testified that DC Health had told him that the school health services program grant had remained flat for next year at 25.6 million. But in your pre-hearing responses and in the contract spreadsheet that was sent to us, we see a decrease of 500,000 to 25.1 million. So what is the accurate number, or what is the accurate number you were intending on funding this grant for?
The school health program is flat funded at the 21 million. The additional funds that Dr. Beers spoke of were additional funds that we gave him from one of our COVID grants, specifically for telehealth. So there might be a misunderstanding when we say that they were flat funding, that he was basing it off of the increase that we gave him from the COVID money and not the 21 million that's in our, the 25 million that's in our
Okay,
budget.
you were saying 21 and I
I
was
know.
like,
I mean,
hold up.
25, sorry.
So they got an enhancement, which was not local funding and not program to continue
Okay, so they got an enhancement of 500,000.
or whatever.
That was
Mhm.
ARPA COVID related that is not included. So we're at 25.1 million.
Yes.
Okay. Now, in your testimony, you said that you feel confident that this funding will allow for same or better service.
Mhm.
But clearly he's operating on a having an additional $400,000.
Well, I think we need to have a conversation, and we've had one internally, about what their core services are as we're looking at fully staffing and working on the training of those staff. I think we have to balance whether or not some of the other things, telehealth or other things, are of equal value, and whether or not we should shift money to more different AOM. So I think there is some reprogramming to be done within that number,
Mhm.
but I don't think it necessarily, I don't think that means that we won't be able to do the same amount of work.
Yeah.
I think we have to make some
Now,
choices.
I left my witness list from yesterday upstairs, but I'm pretty sure he said the 1.3 to cover telehealth and care management is separate and apart from the 26.
Wait, what?
So
What the core funding that they have just covers their training, which we have to look at again. It covers the salaries of the staff, and it covers a big chunk of overhead,
right.
which includes a bunch of stuff.
Right. He was saying, so there are two things.
Mhm.
So you all are saying there's currently 25.1 million there.
Right.
He said in his testimony, they need 26.5 million to provide services at the current staffing levels in FY 25, including paying competitive wages.
Right.
So there is a difference here already,
And not including the additional services.
and not including the additional services.
We'll have a conversation.
Okay.
They just had a union negotiation finished last year, so I don't think we're talking about the salaries of the nurses. They are currently staffing based on the current contract, so we'll have to talk to them about where they feel like the lack is at the point where they're almost fully staffed. Yeah, so I think there's more detail to be had in that conversation than another million, please.
Okay. So we've heard several times over the last few months of school staff who want to have more opportunities to take the AOM training. Have you all thought, now, AOM, I would say, is like the Cadillac. You're getting all the things, medication, first aid, all the pieces. And perhaps, have you all considered, maybe we have a Honda version that's like solid and strong, but not as expensive, that allows for after school providers to take the training or otherwise, but it's not the full enchilada.
I have to look at the curriculum again, but I would caution us from having somebody give medications who doesn't know how to deal with an adverse reaction.
I'm not even referring to the medication piece, but
The other pieces are adverse reaction responses.
no. So we've had, I'm trying to remember who I
Okay.
had these conversations with. I think it was like with the State Athletic Association. So, for every high school game, any high school sport, we are required to have medical personnel on staff when they're competing, et cetera. Okay. We now have kids in middle school and elementary school who are also competing at sports, but we don't have the same level of requirement that there be medical staff, nor do we have a requirement that anybody there know how to do CPR or what I'm saying is basic stabilization before 911 can get to wherever they need to be. And so my question is around that part
Okay, I understand.
of like, You don't need to
So-
know how to deal with administration of medication, but you need to like,
So there is availability of that kind of training from the American Heart Association and many other places. So we are not the arbiters of CPR, but if there is something that the public or council believe needs to be provided by DC Health to coaches and other folks, I need a few things. I need to know how many people is that? And so how big a burden of extra work are we talking about?
okay,
I'm not sure adjusting the current AOM would cover them because I don't know how many of them there are. So if there is something needed, we can look at it. And if that's a requirement that gets created, we will figure out how to do it. It probably will need to be funded and not conveniently squeeze into the money that we already have. But I will say that there are ways to learn CPR that are not about our AOM training.
that's true. I had
Like,
one
just
school
learn
though,
CPR.
the PTA, like the Red Cross was gonna charge them, like the PTA, like $100,000 to do it. I don't feel like the PTO needs to fundraise for
For every
CPR.
school,
I'm not entirely sure how
Because-
many people it was, but the point still being is that,
many a babysitter does it for cheaper.
we as government are providing grants and contracts to these organizations for out of school time activities
Mhm.
for the care of young
Right.
people. And so we need to make sure that,
I would
The-
recommend that we include in the grant the requirement that they all be CPR trained, and they will let us know how much in that grant they need in addition to do that training.
okay,
That is normally how we do things for CBOs. If that becomes that we need to figure out a way that they can economically do it, but having it not be attached to the grants themselves, I think gives us a kind of unfunded mandate that could grow at any size that we don't have any control over. So I'd prefer, if we're going to do it, that we have money to put it together, and then they have money that supports them using it.
okay. Let's talk about the certificate of need process. So the proposed Budget Support Act subtitle VB amends the certificate of need process to exempt ambulatory care centers and clinics with 10 or fewer staff or on a full or part-time basis. What was the rationale behind this subtitle?
So we are in conversations about CON reform as a larger issue. That is going to be a long conversation. That's going to have lots of detail and lots of stakeholders. This was meant as a short-term relief in anticipation of that process, so that some smaller individual places that are more likely to not be, that are less likely to be in a CON process, they aren't included in most places, can start to get going.
Okay. Why does the subtitle limit the exemption to clinics employing 10 or few people? Or I guess, why is the limitation tied to staff and not the type of procedure or the number of patients served?
Because it is an attempt to look at size and not throughput. So the federal government does it based on yearly returns. We cannot do that for new places that we don't have that data for. It's not the way we normally do it in terms of how we use the CON process. So it was looking at the size of what we knew to be the landscape, and we have only some detail because we don't register all of them or license all of these small places.
Right.
Trying to pick up one that was an individual small place and not a bunch of satellites of a large corporate entity.
Okay. How is this enforceable? Like if I'm a, let's say I'm a clinic provider, owner, et cetera, I've got 9 people. I go through the process, I get licensed, I'm open. Now I decide I want to hire 2 more people. Am I supposed to self-report that to DC Health?
The entirety of the CON requires that there be some way in which we learn about differences from what you said you were going to do. I would hope by the time we get to that point that we have done more substantial reform on the process. But yes, that would be my expectation. If you are trying to do that in the time frame that is active, and you have 8 employees and you want to add 3 more people, then you put yourself in the realm of CON that you otherwise would have had to do before you opened.
Okay.
And you got a brief reprieve. And if you want to move outside of that reprieve, then yes.
would I still be able to operate while I go through the CON process?
Yes. But I would say if you are hiring people in a deliberative fashion where you know you're going to hire them, you should be able to finish the CON process before you hire them. So stay in consistent compliance with the CON until you get a CON.
Okay. How does this provision apply to telehealth companies?
It doesn't really. And so that is one of the larger issues that needs to be resolved.
Okay. That's not clear in the language that we have.
Okay.
I'm asking you these questions for the record because I feel like, the BSA is the BSA. There's always sometimes policy adjustments that are attached to the budget. I feel like the CON, any reforms to the CON deserves its own hearing.
Okay.
And deserves a legislative record to answer some of these questions and to allow for testimony. We had no one yesterday who testified on CON, which doesn't match the number of people in my inbox who want us to make changes to the CON
There are many
process.
people who are invested in changes in the CON process. That would apply to some of them.
Yep.
Not all of them, and it certainly doesn't work as a long-standing solution. It is not intended to be.
Okay. The subtitle requires that SHPTA establish a registration process for the clinics that would be exempt under this subsection. Do you know how long it would take for SHPTA to establish that registration process?
No, but I don't expect it to be long because we don't want something complex. We just want to know they exist.
Okay.
So we don't have great visibility about what facilities are in the community. We need to know that to do consistent health system planning. And so just let us know you're out there.
Okay. The subtitle authorizes SHPTA to collect a registration fee from these clinics. And the FIS says that the subtitle would be budget neutral since these clinics would pay the registration fee instead of the CON application fee. How much is the current CON application fee?
It's a range. Come speak to that.
Good afternoon, Terry Thompson. The CON fee is a floor of $5,000 or it's 3% of the capital expenditure.
Okay, so for something like this, you would need to establish a fee schedule, or is it going to be a flat fee?
I don't know that that's been determined.
Okay.
But that is partly why it's not a complex group of facilities. It's a small group.
Okay. Would you guys be okay if I took this out?
Yeah. It'll be long. It does not allow for some places that we otherwise might want, because I don't know the details of everybody who's in your inbox either, from starting their process. It would also mean that some of those smaller places will hire the attorneys they use to do their CON now before we perhaps reform the system in a way that they may not need that. We are working on it, so it is not a years-long process. So it
Right.
will get
Well,
resolved at some point in the near future.
I will say this. I mean, I think I ended my HORA statement and conversation talking about we are going to go through a CON process.
Mhm.
So, and I thought we were all aligned on that. So when we got
We
the
are.
BSA, I was like, what is the
Well,
CON
what I
subtitle?
was asked both by a few different constituents and folks in the mayor's office was to look at what might be some things that would allow an increase in the just economic activity of the industry, because they knew people were trying to start things that they weren't then starting. And so that was what that was. It was meant to be a modest first step to allow some people to start their planning process, to get things moving, knowing that they would be okay on this issue.
Mhm.
But it is not essential. It was not meant to be big enough to be essential. So
Okay.
you can take it out.
Are these changes and or reforms that in a bigger CON, you would legislation, you would anticipate keeping. What I don't want to do is us to pass something and then
Yeah.
6 months down the line, we say, actually, we're going to do something different. We're going to exempt 15 instead of 10 or something like that.
I would, one, I can't really say,
Okay.
but I would expect if it is changed, it'll be that it's subsumed under something much greater and the number won't matter. So
Okay.
not that we're going to go from 10 to 15, but we are going to take out a section or something.
Okay. The proposed budget includes a $200,000 contract for an East End federally qualified health center certificate of need. What's the purpose of this funding and why is DC Health paying for a CON?
I don't know how it was in the budget. I'll have to look into it.
Okay. Okay, SHPTA has a contract for a state plan vendor enhancement. And it's proposed to increase from 118,000 in FY '24 to 250,000 in FY '25. What changed in the scope of work for this particular increase in contract?
Did you not?
That's the
put that number together?
digitizing, that's the vendor we use to digitize the
Right.
documents. So you want to?
Yes.
Okay. So as we have volumes and we get more records that they have to digitize, it's based on the volume of records that they will be digitizing for us.
We have many, many years of
And we have,
boxes of documents.
We have rooms about this size of documents that need to be digitized. So it's volume based, and that's why that contract has
Have doubled?
yeah.
So are we currently not digitizing? Like, are they starting from scratch?
So they have not yet started the
Oh.
digitization process.
Okay,
So we are, as we're moving forward, going to a much less paper-based system as we move to automation.
okay. All right. Okay, finally, maternal health. The proposed funding for the perinatal quality collaborative remains flat at 334,000. At the hearing yesterday, DC Hospital Association requested a 90,000 increase to the grant to implement the Count the Kicks initiative, which is the evidence-based intervention to reduce the number of stillbirths. Are you all familiar with this program and would you be supportive of this investment?
I am familiar with the program. I'm not familiar enough to have a great sense of how effective it is. I know it's evidence-based, but I don't know if what the evidence says the return is. So I would have to look more into it, but any intervention that's effective, I'd be interested in talking about.
Okay. We heard from several witnesses yesterday about the importance of the Healthy Steps program that you all administer, but it appears that the funding for Healthy Steps is decreasing by about 350,000. What will the impact on the program be for that?
The Healthy Steps program was level funded. There should not be a cut in the Healthy Steps program.
Okay, this was in the common budget questions responses. We have it going from 1.35 million to 1 million, FY '24 to FY '25. Can we
Let
check?
us confirm for you.
Okay. The federally funded Healthy Start program, grantees all underspent their funding awards in the last 2 years. It's approximately $300,000 in underspending. How are you guys supporting these grantees to help spend down these full amounts of these grants?
We have entered into a corrective action with some of the grantees, offering them technical assistance to try to help them increase their enrollment. And also a lot of the underspending was due to staff vacancies. So we also are working with them to try to help them in filling those vacant positions.
I don't like to give the federal government any money back ever. So in this particular case, whatever assistance we can provide to these nonprofits, it seems to be a really good program. If they're not spending the money though, then that's people in the community not being served.
And the funding was not lost. We were able to apply for and receive carryover authority for the fund, so we didn't lose the
Right. But
federal.
carryover is limited. So at some point we either spend it or we lose it.
That's true.
The proposed FY25 budget includes 300,000 for a new pilot program for emergency childcare needs for birthing parents. I was excited to see this because this came up during performance oversight. Which division will oversee this pilot?
That would be CHA,
CHA. Okay.
but we do not have a plan for it yet. We're still.
Okay. So my question was going to be, did you all draft the BSA subtitle for this or did someone else draft it?
We did not.
Okay. So let's talk about it.
Okay.
About offline, about adjustments that might be made.
Okay.
In that language. Okay.
We did. Oh, yeah, no.
Give me just a second. Okay. I set a back call to my colleagues and told them, come now, come one, come all. They haven't yet. I don't want to keep you here any longer than you need to be. I'm done with my questions. And the questions that we have, we'll do follow-ups for. So I have a list of follow-ups here. So how many seniors were served in FY23 and FY24 through the funding for dental services for seniors?
I actually have excuse me, it's 105 seniors that were served.
In FY24?
In FY24, yes.
Oh, okay. That's up then more than last year's. Okay, great. What specific FTE positions are being reduced from the Office of Food, Radiation, and Community Hygiene, the Office of Health Professional Licensing Boards, and the Office of Health Facilities? If you could clarify the impact of the loss of funds from the non-lapsing funds that we talked about that are being swept. Details on the state health statistics division, the 11 million and are they new FTEs? Are they not new FTEs? We need some more information about this proposed contract for this FQHC's certificate of need application. And then confirming the funding for the Healthy Steps program. Okay. Dr. Bennett, is there anything I didn't ask you that you'd like to say for the record? You can turn your mic on if you want to.
We've we're trying to get to our resources looking like the data-driven, process-oriented place that we want to be. That means that every change is not going to be about more money. Some of them are going to be about efficiencies or just moving things around to have better communication. But that will, over time, as we get better at some services, that means we will be moving things around to try to figure out what our priorities are and target funding better. So I'm hoping in the next year or so, you'll see that. Great.
Well, Dr. Bennett, I want to thank you and your team for taking time to provide testimony and information to the committee. If we have some additional questions beyond the follow-ups, we'll certainly reach out to your staff and follow up. This concludes today's hearing. If anyone would like to submit testimony, the public record for DC Health will remain open until Monday, April 24th at 5 p.m. Yeah, you can submit your statements online on the DC Council website at dccouncil.gov/hearings. The Committee on Health will hold its next budget hearing on Monday, April 29th. We will hear from the public and government witnesses about the proposed FY25 budgets for the Office of the Deputy Mayor for Health and Human Services and the Department of Healthcare Finance. Over the next several weeks, the committee will be developing our FY25 committee report and recommendations, and the committee will mark up its budget on Thursday, May 9th. The time is 3:20 PM and this hearing is adjourned. Thank you.